With us today are representatives of institutions, international, national, and local organizations engaged on the field of psychoactive substances. The problem of using psychoactive substances exists for thousands of years and will probably never be solved completely. But it is extremely important because it affects functioning of society and requires multidisciplinary approach in order to reduce it to the smallest possible extent. Ignoring this issue leads to its escalation. During this day, we will discuss about policies that different countries in the region of Southeast Europe apply to psychoactive substances. Special emphasis will be placed on new trends in use of psychoactive substances and migrations. We will have the opportunity to hear how countries of the European Union are reacting and how countries that are not yet members are reacting. At the very beginning of today's meeting, Mr. Milan Pekic, Director of Office for Drugs of Republic Serbia, will greet you. Mr. Pekic.
Hvala. Poštovane dame I gospodo,
Ladies and
uvaženi
gentlemen,
gosti,
dear guests,
velika mi je čast
it is
što
my
sam
great
danas
honor to have this opportunity today to be with you.
Izuzetno sam
I'm
ponosan
very glad that the Office for Fighting Drugs of the Republic of Serbia contributed to organization of today's meeting. I'm very glad to have the opportunity to share experience and to talk about the topics that are common. But we have different approaches in solving them. The Office for Fighting Drugs of the Republic of Serbia as a national coordination body promotes programs that rely on all social structures. They recommend cooperation and integration of different levels, such as family, local government, Ministry of Health, Education, Ministry of Education, judiciary organs, police, companies, religious organizations, and other civil society organizations, and other powers in one society. As for the situation in the Republic of Serbia, the situation in fighting drugs is not different from other European countries. In the field of policies, the government of the Republic of Serbia tries to imply the comprehensive policy through integrating multidisciplinary and scientifically based approaches and by respecting all human rights, gender equality and freedom of all citizens. Since the Republic of Serbia is on its way to European integration to European Union, we tend to use and harmonize the national legislation to the acquis of the EU, policies that is implemented regarding drugs by respecting all the differences and that are relative to our culture and other difference. This policy has potential to be the most used in and focus on those activities that have the highest positive impact on citizens, and the proof of that is efficiency and closest connection of the results of policy and social ideas. Thank you very much. Without further ado, I wish you a pleasant meeting.
The project within which this roundtable is organized is financed by United Nations Office for Drugs and Crime. Fariba Saltani will greet you in front of UNODC. Fariba is chief in HIV/AIDS section and global coordinator for HIV/AIDS in UNODC. Fariba, please.
Thank you very much for having us here, and thank you very much to DPN SEE for actually bringing everyone into this room for this very interesting discussion. Good morning to everyone, and again, thank you for having us as a part of the discussion. We really appreciate the work that you're doing as a partner in Serbia. So as mentioned, I'm from United Office on Drugs and Crime. I work in Vienna, and we haven't really been, from our section, very much involved in this region. My colleague Jana has been working on drug prevention and treatment for many, many years in this region, but from the HIV perspective and looking into the blood-borne infections that are associated with drug use and prisons, which is our mandate area as well, we haven't been very much involved. And we had some funding, and this gave us the opportunity to engage in a discussion. So I'm very, very pleased to be among you and to hear and learn from you, actually. I'm going to give you a small update on global statistics, on why we are doing what we're doing. We are a co-sponsor of UNAIDS, the UN Joint Program on HIV, and UNODC is the convening agency for addressing HIV among people who use drugs and also in prison settings. According to the latest UNAIDS data in the In Danger report, 70% of all new infections globally are among key populations and their sexual partners, which include people who use drugs. Although we've made great strides in prevention in other population groups, it seems that globally we haven't really been very successful in addressing people who use drugs and in making sure that we prevent HIV, hepatitis C, and TB amongst this population group. People who inject drugs are at 35 times greater risk of acquiring HIV infection than people who do not inject drugs. HIV prevalence among people in prisons is 4.3%, and people in prisons are 6 times more likely to be living with HIV as compared to adults in the general population. And if you look at the incarceration rates, the people who are in prison, we have more than 11 million people in prison at any given day. And the overcrowding in prisons is a problem in all countries. This is something wherever we go on to a country for support, they're coming to us and asking, how can we make sure that we reduce prison overcrowding? Because this leads to a lot of violence, it leads to precious resources going out of the health system and being spread so thinly in prisons that we cannot really achieve anything. The high occupancy rates are conducive, make the facilities conducive to violence and higher transmission of HIV and other bloodborne diseases. And majority of people in prisons return to the community actually in less than 1 year. So we really promote that we have to look at alternatives to incarceration when we're looking at drug policies. Of this over 11 million people who are in prison, actually 2.5 million are estimated to be convicted only on drug-related charges, and 22% of them for drug possession and personal use. So you can imagine it's a huge number. And do they really need to be in prison? And one interesting point about these figures is that the proportion of women imprisoned for drug-related offenses is 35% compared to 19% among men. So you can see that the problems that is being created for women who are using drugs or who are being used as mules in this industry is much greater. And if we are trying to support and really solve the problem, we need to look at this issue very closely. As I mentioned, we are UNODC, but we also have a responsibility as a co-sponsor towards UNAIDS. So we are implementing two strategies in synergy, the UNODC strategy and also the Global AIDS strategy. And in both of these strategies, what we promote is human rights-based, gender-responsive drug policies, and making sure that we look at alternatives to incarceration, that we do not overuse the criminal justice system to deal with the drug issue in our countries. And we have all the tools. It's not, we are working with our partners, actually very closely with our community and civil society partners. We are very proud of the close relationship that we have with our community and civil society partners. We have a group of civil society and community partners who work with us. And for every tool, every guideline that we produce, it's done in close collaboration with our partners. Not only the civil society, also with WHO and also other relevant UN partners. So we have the tools. We have all the training packages. We know what works. Last year, the WHO published their technical guide on how to address HIV amongst key population, where they clearly highlight what are the interventions we need to have. We need to have harm reduction, which is as in the WHO document, it's inclusion of needle syringe programs, opioid agonist treatment, and overdose prevention. This is what is harm reduction in the WHO definition. We know this works. We also have guidelines on how to work and how to engage different stakeholders, including ministries of justice, ministries of interior, the police, the law enforcement, and bringing them together to listen to each other, to listen to the communities of what needs to be done. So we have all the tools. There is no excuses for not doing better. So we really need to just look at what is happening in each of the countries and how we can bring these interventions to scale. Because in some countries, we tick the box that we have methadone maintenance programs, or we tick the box that we have needle syringe program, even in prisons. But when you look into the coverage, it is so limited that really has no impact on the epidemic. So I urge you, and I'm really here to learn from you about the situation in this region, and my colleagues will give you a bit more details about what we are doing why we are here, and also what we've been doing in the region. But I think we have everything in place to really work together and come to an understanding of what we need to do so that we are not in a similar situation in 5 years' time, in 2025, where we've made commitments to reach these, targets, to have the community-led responses, to have less punitive laws, to have less stigma and discrimination, and have better news to go out to the world for people who use drugs and people in prisons. I thank you again, and I stop here. Thank you for listening to me. Thank you.
Thank you.
Thank you, Fariba. We hear that this project is financed by UNODC. Name of project is Emergency Support for Provision of HIV and Harm Reduction Services among key populations in Ukraine and refugees in selected neighboring countries. Ms. Gorica Popovic will present this project to us. She is a specialist in law enforcement and HIV sector in UNODC. Gorica, please.
Thank you all. Good afternoon, good morning from me as well. I'm very pleased to be here at home, in my case. I'm very pleased to meet all of you, some of you for the first time, some for second time. But in any case, I will try to keep this short because obviously the priority for us is to hear our partners to talk about their activities. So I will just briefly present what this project was about, what was the incentive to have this project focusing on specific selected countries, and just a very briefly bit about the activities that are included in this project. So as you know, and as you've all probably witnessed it in your respective countries that received a lot of refugees, the war in Ukraine triggered one of the fastest growing displacement and humanitarian crisis, pushing millions. I think the latest numbers are over 8 million of refugees have been pushed into seeking safety and security in neighboring countries, primarily countries surrounding Ukraine and Western Europe, but also significant numbers have been recorded in countries of Western Balkans, such as Serbia, Montenegro, and other countries in the region. Massive devastation, especially in civilian centers and especially for medical facilities that have been targeted, caused the situation where a lot of services have been disrupted and service providers have been either unable to work or also severely displaced themselves. In such circumstances, vulnerable populations, groups that are in general disproportionately affected by low service coverage or access to services, have been had their situation exacerbated by the current humanitarian crisis. People who use drugs, people living with HIV, people in prisons, and especially women from vulnerable groups, have been left behind and very often excluded from emergency humanitarian response. So, and obviously, moreover, the threat of gender-based violence in such situations have been obviously increased and put these groups in even higher risk. This project, as it was already mentioned, is targeting primarily a community-led response. The focus is to deliver necessary services to those who need it, but to be delivered by those who are best placed to deliver these services in selected countries. As it was already mentioned, our focus in this particular project is on 4 countries: Ukraine, Moldova, Serbia, and Montenegro. Primary objectives of this project are to ensure continuity of HIV prevention, treatment, and care, including OAT, opioid agonist therapy, and ARV services for people who use drugs and people living with HIV. Moreover, as I said, one of the primary objectives is to have community-based or community-led treatment, care, and support for these populations. And finally, provision of immediate support, shelters, food, and other basic livelihood necessities for these people is also a significant part of this project and is being done with a coordination with civil society organizations and local authorities. I will not go too much into details on the activities because, as I have said, the idea and the desire is really to hear from our implementing partners, for which I can say, at least for the partners that are here that have so far been doing an excellent job. We have 7 organizations in total focusing on Serbia and Montenegro, and we have additional organizations for Ukraine and Moldova. As I said, the activities are abundant, and the work started in December last year and is intended to go on until end of May this year. Again, I really want to strongly thank and highlight the great work that the partners have been doing in these countries. And I'm also very grateful to the office for hosting this event and also for being very supportive of our civil society organizations. And from my side, I really look forward to actually seeing the end result of this project, because not only that it's very important, it is also promising, because delivery of such excellent support to our key populations is a great start for continuation of such activities in the future. Thank you very much, and I wish a good working day to all of you.
Thank you, Gorica. Now we'll have opportunity to hear about situation with refugees in Serbia from Mr. Goran Radisavljević from Timok Youth Center, Mr. Aleksandar Prica from Association Rainbow, and Ms. Irena Molnar from Regeneration.
Dobar dan svima, ja ću konsultovali smo se između kolega u duhu zgrade s obzirom da se
Well, in the spirit of this building, because we are located in the building of the government of the Republic of Serbia, I shall be speaking in Serbian or the Balkan language or Dobar dan language, because quite a lot of peoples from this region speak pretty much the same language. Well, generally, I shall provide a short overview. This is as we agreed, so that other colleagues from Serbia could say something into more detail about activities in the field. First of all, I would like to say that this program and this project that we are implementing is generally quite good support when we talk about refugees from Ukraine and Russia, but also, as importantly, and once I've given you the data, you will see why this is so important. Well, it is the support to our national response, first of all, when we speak about HIV prevention, but also support to key populations. We have about 180,000 refugees from Russia and Ukraine, not as many from Russia as from Ukraine, maybe 35,000 from Russia. We also have about 5,000 of them from Belarus. Ukraine has 42 million population. Serbia has 6 or 6.5 million. So the assessed number of intravenous users is 300,000 for Ukraine, about 40,000 for Serbia. MSM population in Ukraine in Serbia is 40,000. Ukraine is larger. 169 people are familiar with their status. 122,000 are HIV positive and use therapy in Ukraine. In Serbia, this figure is 2,200 or 2,300, so that's great disbalance. There are no persons which are exposed to risk. So it's very important to provide support to these people, but it is very complicated and difficult to work. There's this key question of all populations who contacted us. They come to us in fear and they ask us if we can provide them a service, and then they feel the pulse in order to learn whether their rights as refugees are affected, if they are HIV positive or if they belong to any critical population. And it is only then that they will say that they are representative of a certain population, whether they use the therapy or not. And now that I've mentioned therapy, there's yet another issue. Serbia is one of the leading countries when it comes to therapy and the state of affairs. So the therapy differs as compared to the therapy administered in Ukraine and in Russia. So the question is, how do we treat persons who were on one kind of therapy in Russia or Ukraine? So how do we administer another type of therapy to them when in Serbia? And certainly in this we're supported by infectologists and clinics and so on. Certainly it is very important to target experienced organizations, and there are 4 organizations that work in the field: Prevent, Duga, Regeneration and Tox. So the regeneration treats new drugs. So the 3 organizations divided Serbia into North, West, East and South. And the 3 organizations, well, a large part of this population is located in Belgrade. Belgrade is such a large city, and beside the fact that Novi Sad is the 2nd largest town in Serbia, believe me, when you take a walk the city of Belgrade. Sometimes you feel you're not in Serbia, that you're in Russia, that you're in Ukraine, because you can only hear Russian and Ukrainian language, especially in restaurants and especially at night. But this is really astounding. You cannot simply hear Serbian language in restaurants, and I'm talking about the central Belgrade. So you will later on see, my colleague Alexander will impart data to you. There are clients. We organized a meeting with decision makers. The PNC, we triggered this meeting. We arranged certain steps with institutions so that all refugees can get information about our work and about support that they can get. So apart from field work and prevention, we also provide psychosocial support, support of epidemiologists and pathologists who can also assist this population. So, beside all this, I'm sorry I cannot show you this in Ukrainian and Russian because of the approval that we are waiting for from Google and Apple. We used to have this application which provided for anonymous communication with our field workers and with advisors when it comes to mental health and HIV. So they had a map of Serbia and they could contact the organization they wanted to work with. The application has been upgraded, also translated into English, Russian and Ukrainian, and so you can select all these languages. So it's possible to contact one of these 4 organizations depending on where they're located, in which territory, in which city. The application is anonymous and you needn't enter the data. Whoever is registered for the first time, and it is encrypted, so whoever enters it for the first time, they get a code and then they use this code all the time. So it is encrypted and it is safe when it comes to the population. So with the good communication that we have with Ukrainian organizations that operate in Ukraine and that have contact with their key populations, we shall try to promote this application in order to reach as many clients as possible. And certainly I hope that this will be to mutual benefit and satisfaction, because this is not only support to refugees who just dropped in here and have no support. They need support for mental health, and they also need support for their overall organisms. But this is also support to our national response. I gave you the figures at the beginning. It's enough to say that we do not have controlled population, and we shall be faced with HIV epidemic in a year or two, unless this is channeled in any manner. So I would like to go into details. So I would like to give the floor to my colleagues to tell you something more about the activities.
Poštovane dame, poštovana gospodo, prvo da vam svima poželim dobrodošlicu u Srbiju i Beograd.
Welcome you to Serbia and Belgrade, to all of you who are not from Serbia. And as Goran mentioned, we have agreed how to organize our speech today. It is very important to say that all organizations are working as one in Serbia, because this is the only way to function properly. And we'd like to thank Gorica especially for this, because she's keeping all us gathered together. I'd like to mention the services that we offer within this program. Duga, as organization, has existed for 12 years and provided different services. Prior to the project, we have already had clients and both from Russia and Ukraine. And we can thank for that our partner organizations for EU who addressed the client to us, because we had an insight from the very beginning of the events in Ukraine. As for the services that we offer at the territory of Serbia, Firstly, these are the outreach services, which are really the most adequate method of work when it comes to these populations who are very difficult to reach. That can be a less institutional framework, but it is very, very important when it comes to MSM population. So it is essential to have online outreach, which is mostly seen in Serbia, which we saw during Europe Pride in Serbia when we had the measles problem, and we covered more than 8,000 visitors of Europe Pride in order to reduce the possibility of monkeypox. Sorry, so when it comes to crisis, this is something that we get organized well and quickly. As we also have a checkpoint and all the services that we can provide in the field, we can do it in checkpoint. We'd like to thank the Ministry of Health with which we have been associated from 2006. We have 2 medical units who are testing on HIV, and this is just but one service that we provide when it comes to tests. These are fast tests, and within 20 minutes from taking their capillary blood, we can give them the test results, and the test is 99.9 sensitive to HIV and hepatitis. Another important service is psychological support, and we have here, when we have people coming from Russia, when it comes to LGBT population, we have need for therapy support due to homophobia, which has been internationalized, and some people, due to their had problems in Russia. When it comes to Ukraine, we have more problems related to war, and our clients, they require psychotherapy in that respect, and when we give them HIV positive results, and to persons who have come as HIV positive persons also need this kind of support. Additional support and service is the peer support, when support is given by people from those communities. These persons are usually educated but not necessarily health workers, and we have epidemiologists in our project, but we also need dermatovenerologists, and we have one attributed because we have problems with syphilis. You will see the details and add about other gender diseases. One of the services is monitoring of institutions. Our teams, they have support for health and other services. They can monitor the client, and it is necessary to help them with translations. Today is the International Day of Mother Tongue, and it is essential that apart from English, we have all the materials in Ukrainian, in Russian, so we can provide different sets of services to those people, and depending on the services provided. Besides, as Gorica said, for a number of clients, we have a possibility to help them with their therapy, and when it comes to food and hygienic conditions. This is just for a number of clients who do not have financial support and financial means, so we can meet their requirements. requirements. But I believe that in future, as a state, we will need more financial means with regard to the data that I will give you today. When it comes to Duga Association, in the last 3 months, as we are doing this program, we have 221 clients. 19 of them had reactive results, 17 HIV positive, 1 result is only reactive to syphilis, and 1 to HCV, which is around 8% of all of our clients. So 8% of persons are affected. Out of these 17 HIV positive persons, there are also, I have to say, persons with multiple infections, but out of these 80 is reactive to syphilis and 4 are reactive to hepatitis C. Out of these 17, a total of 14 are males, 3 are females, and 13 persons came to Serbia. They knew their HIV status. 4 of them were discovered at our checkpoint in Belgrade. So these are the data in the last 3 months. This is what I got last night, and what we have noticed when it comes to MSM population. There are some overlapping risks. Very often, people from MSM who are providing sexual services, they use narcotics. So and that's that is a big risk, and we have couples who also from Russia and Ukraine who are in partnership relations with Serbian citizens, and they require services of testing and support, and definitely much more clients, male clients, come from Russia, and more females come from Ukraine. These are some statistical figures that I can present you right now. If you have some further questions, I am at your disposal. Thank you.
Dobar dan I od mene. Ja sam Irena Molnar I izvršna sam direktorka
and I am the executive director in NGO Regeneration. I shall not repeat what my colleagues from Rainbow and Timok Youth Center mentioned. I'd like to say that Regeneration implements several activities within this project, which are not aimed at injecting users, beneficiaries, but also users of psychoactive substances who use new psychoactive substances and stimuli. And these are mostly foreigners that we mapped within the activities that is aimed at mapping needs of persons using drugs in Serbia. So actually, harm prevention programs which are not really available in Serbia. When it comes to harm reduction, actually our NGO is the only one who deals with this. We are a community-based and community-led organization, and we also have advisory services, peer-led counseling, online peer-led counseling through UNODC methodology, which is now adapted for the needs of Serbia. I would like to say that we have some users who ring us to learn what kind of services are available, and harm reduction services comprises referral service to different services which are available. So we cooperate with all the organizations that are active within this project, as well as with state institutions, and through our component of the project we're trying to map which are the easiest and the fastest ways to access services for people who use stimuli and new psychoactive substances. There's another component that we shall implement in cooperation with the DPN CEE office, Services for Women Who Use Drugs. That's the only organization that, with support of the Anti-Drug Office, was accredited in the social protection system for women that use drugs and in the system of gender-based violence. So in these terms, this training will be adapted to needs of this training and delivered in mid-March throughout Serbia. So I do hope that service providers, both NGOs and state institutions, will be more sensitized towards this issue, and that we shall try to raise capacities. As my colleague Alessandra from Rainbow said, we have women who are from Ukraine, because men from Ukraine cannot travel, who are positive, HIV positive, but they do not have any services in Serbia. There are very few services, and which are also not aimed to women, but they are adapted. Well, there are services which are intended for certain populations, but they're not gender sensitive, so if a woman approaches us, we shall not deny her service, but we shall also try to raise awareness on how to think about services which need to be aimed to women and adapted to women. So as my colleague said, everything else, thank you very much. I wouldn't like to go into detail, but I'm glad to take any questions.
Thank you, colleagues. The project in Montenegro is implemented by our member organizations Juventus and Cazas. In front of these organizations, Jelena Čolaković and Mišo Pejković will speak about situation in Montenegro.
Hvala najljepše na prilici danas da govorim. Ja ću također govoriti na našem jeziku.
I will also speak in this mutual language. And the fact is that we are privileged to be here at this round table, but we should not neglect that such privilege is given by the people who are sitting behind us. So I would like to thank the colleagues who are here, but they do not have the opportunity to sit around the table, because they are the ones that enable that we work what we do. We who are presenting, we are glad to have opportunity to present. As for Montenegro, there are a couple of things that I would like to mention. And starting with the fact that Montenegro has over 700,000 inhabitants, and since the beginning of Ukrainian crisis, some 100,000 Russians and 500,000 Ukrainians came to Montenegro in the first 90 days of the crisis. So we have data that temporary residents, prolonged residents, and permanent residents are requested by 13,500 Russian and 300,000 Ukrainian citizens. So when it comes to communities, we are providing services to the persons who are using drugs, former prisoners, LGBT persons, and some estimates are that we have 2,300 people using drugs. In Podgorica, only 1,200 people. These are just the figures related to this group. What is the Juventus activity? I'd like to thank UNODC and DPNSEE for inviting us, because these activities are complementary to the services that we have been providing related to support to the HIV strategy, particularly. Unfortunately, I cannot say the same for the drug strategy because we do not have that strategy, and some previous efforts to implement that strategy did not give some significant results. So, in order to reduce damage, so the only program that gave results was the program of reducing damage, and they provided good results, and in the strategy from 2030 to 2020. So this speaks about the commitment of our state to this problem. However, this has been in focus more lately. As Montenegro, we have finally have this opportunity to more systematically approach the persons who are injecting drugs. Related to the previous time. Juventus is operating in this field from 2004. We have capacities and knowledge to address these problems, and when it comes to projects funded by UNODC, this project is developed to activities that are put into several clusters. I'm explaining this. This is the support to health care to be provided to people coming from Russia and Ukraine if they belong to these groups, and the focus is on mental health, which is related to HIV. Additionally, we have support in providing damage reducing and reducing HIV through the activities of our dropping centers and in the field. And a good part of this project is the fact that we have promotion of capacities of our staff and people who are working, which you cannot often see in programs that are similarly funded. We have opportunity to promote our knowledge, and that is funded by donors, and we have opportunity to learn further what is going on in the region, in the world, as for the damage reduction. In that sense, we are grateful for this opportunity that we can learn through this program about what is our job, focused on structured trainings, but also trainings with the healthcare system and child protection systems, which resulted in additional training 28th of February, which is uniting police capacities, security services in our state, Center for Social Work, for Social and Child Protection, and Health Protection as well, who are the first responders when it comes to people coming from war-affected areas, more concretely Russia and Ukraine. It is very important for me to underline we're not talking about great figures. Our coverage is not that big, but we need to relate that to the fact that these communities in Russia and Ukraine were very much affected regarding stigma than in Montenegro. We're not going to compare. We're not comparing the countries who are much different, but we're talking about the countries where we have just small differences when it comes to Ukraine and Montenegro, for example. I'm not taking into account Russia. So these
područja gdje su
communities
stigma i diskriminacija
they come from the areas where stigma is pretty high. But in Montenegro, they also face some
vrijednosnim sistemom koji nije
value
usklađen sa onim
system
što
that
je
is not
naša
aligned
naša
with what
vrijednosna baza.
our value base
smo govorili na
is.
samom
That is
početku,
something that
da je
we
to bazirano na
talked
ljudskim
about
pravima, bazirano
before,
je između ostalog na
that we have based
people-based approach,
people-based approach,
imamo, jeli, osobu u fokusu
when we
i
have
važno je to
a
što je
person in
osoba, jeli,
focus,
osoba, neovisno od toga koja je
regardless
identitet,
of
odnosno koja je njena lična
the
karakteristika zbog
identity
koje
or
nas obraća
personal
za podršku
trait
i
for
pomoć.
which they are approaching us
U tom
for
smislu mogu
support.
da kažem
And
da smo se mi
in
prilično
that
adaptirali
sense,
okolnostima
I can say that we
koje
have
su
adapted
karakteristične
to
za
the
ljude koji dolaze u našu
circumstances
zemlju, došli u našu zemlju,
and
pa otuda i
as
online
for the
outreach
people
dosta
coming,
jak,
so the outreach is
samim tim što
very
ljudi
strong.
ispituju
People are
gdje su došli, kako su zemlji došli,
people want to
i sa
see
kakvim
where
ljudima
they came,
i dalje žele da
how
komuniciraju ili komuniciraju.
they are going to communicate
Tako da,
with people in
ja bih rekla
Montenegro.
da ovaj
So
program
I would
ima
say that this
neku
program
dvojaku
has
komponentu,
a
ne samo što mi
double
imamo priliku da
component.
pokrijemo
Not
jedan veći
only
broj
that we
ljudi,
can
odnosno
cover a
civilnosti
great
državljana,
number
kad
of
govorimo, već
people,
imamo priliku da učimo
citizens of
o nekim
Montenegro,
drugačijim
but
kulturama
we
i
can
da
also learn about
između
different
ostaloga,
cultures
unapredimo svoje
and
kapacitete
promote
i
our
znanja
capacities
kad
and
govorimo
knowledge when
o
it comes
onome što je
to
naš
what
posao
our job
ranije.
is in
Ja
previous
sam
time.
naravno na raspolaganju da odgovorim na dodatna
I
pitanja.
can answer any further questions if you have. I would stop here and give possibility to my colleague Misha Perkovic to add something or say something new, maybe.
Hvala Jelena. Pa evo kažem u maniru da nastavimo našim jezikom, samo što bih ja ispravio, ja sam osnovno
I will continue as I will speak Serbo-Croatian, which I learned previously, and we are in the building of the Federal Executive Council of the former country. So it is necessary to give support to Serbia and Montenegro when it comes to refugees. I would like to reflect the facts about Montenegro. You've heard from Jelena and you've heard some data. 170,000 people are in Montenegro, and Podgorica, which is the capital, has 200,000 inhabitants. That speaks for the percentages. We should not neglect the beginning of 2009 when people from Ukraine came to Montenegro. They have their schools, they have their kindergartens in Budva, in Podgorica. And what is important, they have their documents and they have free of charge health protection and treatment. And I also want to tell you that Ministry of Interior of Montenegro is committed to that. Every year they update their documents and they inform the people from Ukraine that the government of Montenegro that their status is going to be kept until March 11 to 2024. And with proper documents, they have free of charge health care. And I think that the fund for health is under pressure because we are giving this health protection accompanying, of course, with the documents proper. However, the persons without documents are also here, and Jelena has mentioned, and both Sazas and Juventus are continuously working in harm reduction for intravenous drug users, and we have drop-in centers for where we exchange needles and syringes with help of doctors. Through our drop-in centers, we have understood that refugees also need this kind of service. What I also wanted to say is that it is essential, and I agree with Jelena, that Montenegro has no drug strategy. It is important for the civil sector, who are all doing that, to put some pressure on Ministry of Health to make this, to draft this strategy as soon as possible. And I believe that together with Juventus and other organizations who address this topic, we will manage to have drug strategy this year, because without the strategy we are just wondering. As for the civil sector, we are doing our job, we know what we need to do, but if we do not have an appropriate strategy, we cannot know how to jointly act in this field. What I want to mention also is, especially I'd like to thank DPN-CE network in UNODC, that we need additional support to civil sector for the displaced persons. Thank you very much. I'm here for any other questions.
Thank you. The aggression against Ukraine has been going on for almost 1 year. The first countries where refugees go are Poland, Moldova, and Romania. The ARAS organization is the most active and largest organization working on the field of drugs in Romania. ARAS is member of DPNC network, and Nicoleta Dascalu is the vice president of our network. Nicoleta will introduce you to the situation in Romania when it comes to working with refugees. Nicoleta, please.
Thank you very much. So, as you mentioned, ARAS has been working in the field of HIV prevention since 1992, which is more than 30 years now, and we are doing mainly prevention, support for people living with HIV and their families, and also advocacy for human rights, very broadly speaking. About the services for the Ukrainian refugees, we worked in two directions. First of all, we provided ourselves the services we were requested, which is mainly methadone substitution treatment, because we have two centers run by ARAS in Bucharest where we provide methadone. Then housing. We quickly organized at the end of February, beginning of March last year, we organized one of our offices. We turned it into an apartment with 2 rooms, and we bought whatever it was needed to house people from Ukraine. We also provided social assistance for the Ukrainians who needed, for example, documents to access services in Romania. And also support for transport to the planes or to the trains, because maybe you know, Romania was mainly a transit country. So Ukrainians came to Romania, but they didn't stay there for a long time. They stay until they received the plane tickets from their relatives, mainly from Italy and Germany. So what they needed was somebody to help them get to the airport and continue their transition to other countries, Western countries. Another important direction of our activities was the linkage to other services. So it was mainly public services in hospitals, and I'm talking here mainly about people living with HIV who needed treatment, needed to continue their treatment in Romania. People with hepatitis, mainly hepatitis C and hepatitis B, of course. and also people with complex situations, like people who needed psychiatric treatment. And we had several cases of mothers who came with their children and who were HIV positive, or they had hepatitis, and they also had the psychiatric problems. And that was a little challenging, we have to admit it, because of course they didn't speak Romanian, they didn't speak English. So we worked with translators, but well, we managed to solve the cases. Another direction was the fact that we needed the money to provide these services. We also offered material support for these families, like food or hygienic products for the kids. And we did public fundraising, and we were impressed by the big number of private persons that donated to ARAS for the Ukrainian refugees. And all the human resources were put by ARAS voluntary, so our colleagues provided voluntary work. And at the end of last year, we managed to have a small grant from AIDS Action Europe for about 4 months, where we could buy materials, hygienic products, as I said, food and so on. At present, we do not have any, let's say, Ukrainian beneficiaries, but we are in contact with other NGOs working in the field and also with the public institutions in Bucharest, like Directorate for Social Assistance of the City Hall, and also with the institutions all around the country, because there were people coming to other cities and needing, for example, methadone. And the problem with methadone is that in Romania it is provided only in Bucharest. It's very difficult to get methadone substitution treatment in other cities. So let's say it's still a challenge. And as a last mention, I would say that this crisis has been like a challenge for the medical system in Romania. And they discovered what the problems are, because we have several problems in the medical system in providing services for the Romanian people. But now with the Ukrainians coming, these problems appeared even more strongly. And we really are looking forward to some changes in the service provision in Romania after this crisis. So fingers crossed for this. Thank you.
Thank you, Nicoletta. About epidemiology of HIV and viral hepatitis and harm reduction response in Southeast Europe, will talk our director, Milutin Milošević.
Thank you. Good morning, everyone. I will speak in English because the presentation is done in English. But I hope that everybody will understand what it is about. I tried to move the... Can you maybe move instead of me the presentation? So this will be, I prepared some of the data about the situation in Southeast Europe as a whole, and also some which were provided by the, this is the second part about Western Balkans, but if we go on, the next slide will present you the overview of situation created by harm reduction, global harm reduction report, which is produced every 2 years by Harm Reduction International, big international organization, which collects data from formal institutional sources. So this is formal data. I have to say a small problem is that some of the data are taken from the documents which are pretty outdated, you know, and but this is what is formal. For instance, there are countries which didn't have their biobehavioral survey for a couple of years, so the last data are from, let's say, 2014, 15, 16, or something like that. So the situation is, at the moment, this report was published late last year, so these are the most accurate data which you can find over there. And there is the link where it is. I just now extracted some of the elements of this. So if you look at the number of people who inject drugs in the countries of Southeast Europe, the green are those countries, if you see to the right, the countries where we have the drop of number of people injecting drugs. And you can see that Romania has the highest drop, which may be a result of different, maybe, way of collecting data from previous to this one. or maybe can be a result of something else. But there are also countries which now report increase, and it is quite a significant increase in numbers of people injecting drugs. And you can see, for instance, Montenegro is 77%, which is, again, may be a result of better collecting information or better reporting of the situation, and not that now many more people starting injecting drugs in between the two. But this is very important. The whole thing which I'm trying to show you is very important, because we always try to do policies, measures, activities based on real results, what we call the evidence-based strategies. And this is very important, that the data we have are accurate and real and new. And then the next thing which I can show you is the information about the diseases which are transmitted with the use of blood-transmitted diseases. And you will see here the general atmosphere in the region, reality in the region is that HIV prevalence is not so very high. And again, it doesn't mean that there is no HIV. Maybe the result is that we have good services, prevention services, and I'm quite sure that that's the case. So you can see that there is already a slight increase in Bosnia. There is a quite significant increase in Romania and also in Slovenia, while we have a little bit better situation in several other countries of the region. The second column is about hepatitis C, and that's actually where the problem is in the region. We have very high prevalence in the region, and that is something which is really probably the biggest problem with for people who inject drugs. Maybe the result is that we don't have so many, so good, so strategic, so quality services which are preventing and treating hepatitis C, and that's very obvious from the data. And again, maybe you can remember, especially if you are from the countries where you come from, the percentages which are there, which are actually, later I will show you maybe a little bit more different data which are from our member organizations, which show that the situation is even worse. And what we collected is that in more than 50% of the countries of the region, Hep C prevalence is over 50%. So it's to the record. In the previous one, it was record in Romania was 88% of people who inject drugs have Hep C, which is very, very bad situation. And then there is also the information about Hep B, which is not so very accurate because it's not so much related with injecting drug use. And then there is the offer which we provide to the organization. These are all the harm reduction services which are available in the countries. The worst thing we have at the moment is that there is no more services in Bosnia. They all closed. There is no more services in Bulgaria. They closed. Bulgaria 3-4 years ago, Bosnia effectively maybe a year ago, there were some outreach services, but not real service. Service was there. There are also drops in other elements. You can see the red things, which means the increase of the drop of services available. Green means that there is more and more. When it's, for instance, Romania, it's only now, as I understand, in Bucharest probably. Everything else is already closed. So that means that if a person needs support, we'll have to travel, I don't know, a few hundred kilometers to come to Bucharest for a service, you know. And that's a very, very, very problematic thing. There were more data 2 years ago about the opioid agonist therapy. Now it's just with what is available. There were also data about how many of them are available, but now this is what is present there. And then when we talk about this very specific, we would call it modern services which we can provide, and these are things which are what I said recently, the evidence-based things which worked in many countries where we introduced them, but they are not still available legally, or however you want to say it, in many countries, and especially, as you can see, in Southeast Europe. Peer distribution of naloxone is only available at the moment in Slovenia, and there is a lot of information. There is a very good UNODC support to Southeast Asia about Southeast Asia about peer distribution of naloxone, which save life of people. The program in Scotland for 3 years saved 3,000 people from overdose deaths. And it includes peer, and not only peer distribution, but also people who are in contact with people in the critical time, like police officers, family members, colleagues, and things like this. These programs save lives. It's only available in Slovenia at the moment. And we all try to have it. I mean, it is available in ambulance, but it is not really so quick, which is important, yeah. Then the second thing, the drug consumption room, we have finally first one opened in Greece. There was a big process of legal change so that this will be available. And then finally last year we had a very good example with the opening ceremony of this with the presence of the Prime Minister, the Mayor of Athens. And that is something where we try to help people to use drugs in an organized way, where we also provide support, psychological referrals and things like this, and people would do it anyway, so let's try to help them in that process and then bring them on the side of treatments and then recovery and everything else. And also, this is very new thing. The last column is completely new. It's about safer smoking equipment. It's especially for the smoking cocaine. And that is something which is newly opened, and we have only one opportunity at the moment happening in Slovenia. So the data are not as we would like to do, and there are different things, and I think that this is very important when we talk about what we should do and how we should do it. We need to know this information. I prepared several, as I said, maybe we can just run through if you want, but here is the comparison where you can see that, again, HIV is under control, I would call it. I wouldn't say it is not a problem, but it is under control. While Hep C is a big problem for which we don't have quite adequate reply. The presentation, I think that we don't, but I will send you all the presentations. So for every of the country, we have the information for our member states organizations about what is available, for instance, in Albania, what is available in Bosnia and Herzegovina. We can see the data on the bottom. After Global Fund left, before that, we had 11 to 14 newly positive people tested. And you can see how it developed year by year. 23, 28, 43, 60 last year. 5 times more after the services stopped. And then we have more or less the same situation in Kosovo, where Kosovo, what is not listed here is their problem with cocaine, which is even worse, and most people are dying from cocaine than from HIV and HEP. Then the increase in Montenegro, which was already reported by our colleagues, is there. A specific problem with Montenegro, with Macedonia, where we have a couple of services closing, and drastic drop, like cut of the budget for this year is something like 50%, if I can remember well, less service money, and so that our organizations are forced to close several services which are available, and it was one of the flagship countries in the region by the services, and also a little bit better situation in Serbia, where we have a stable global fund financing for the last couple of years, and it really proves that when there is a support, then there is a result. So yes, you can have some more on our resource center, but as I said, I will send you the presentation so you can see that our data, which are, I mean, you all know that the best channel to access users is through civil society organizations. So we know these people, and we see where the data are not really good. And I really think that we should try to start merging data, governmental and civil society, to be on a better ground when we create services. Thank you.
Thank you, Milutin. Today, Frederick Doneker and Katerina Škarupova from European Monitoring Center for Drug Addiction and Drugs and Drug Addiction are with us, and MCDDA evaluates drug policies in different countries. About this process of evaluation, today will talk Katerina Škarupova. She is a scientific analyst on health in MCDDA. Katerina.
Thank you very much. I hope you hear me well, because I tend to speak slowly, very quietly and very rapidly. So just a note for the interpreters, if I'm rushing through, let me know, wave to slow down, because I prepared for 15 minutes, but really rushed through. If I can, next slide. So I work for the European Monitoring Center. Okay. Yeah, we have the... It seems to not to work. Okay, I speak and then we move to the next slide. So I work for the European Monitoring Center for Drugs and Drug Addictions. For those that are not familiar with our work, I will just summarize that we are an EU technical agency that has the objective to support the member states with the factual and reliable information on drugs, drug addictions and the consequences on drug use. One back, please. We work with the we work with the network of the national drug observatories that we refer to as the national focal points, but we also increasingly involve other stakeholders such as civil society organization, for instance, through the correlation network. I also wanted to say that we work also with the Western Balkans region under the IPA project, where we try to help the candidates, potential candidates countries to the EU to integrate them in the work of the EMCDDA. Can we go back a little bit? Two more slides to the third one. About this presentation, it's called. So what I go and then we maybe see the slides. What I want to do with this presentation is actually on behalf of our colleagues from the support to policy sector to give a quick flight through the work the EMCDDA is doing in the drug policy area. I also want to say a few words about the EU drug policy, and I hope I will manage to highlight how the evidence-based approach to drug policies and also the ongoing evaluation of drug policies is very important for the policy-making process, and that will also help to national stakeholders to react to a crisis like the one you have now with the immigration or the one that was related to COVID. Next two, yes. First about a bit of definition, the umbrella slide, please.
It's here. It's working now. It's working.
Perfect. Thank you very much. Sorry for this. So just a few concepts. The EMCDDA, when we speak about drug policy, we actually mean the overall vision of the government, the direction that the government wants to take on the drug issues, and then drug strategy, action plan, coordination mechanisms, and evaluations are actually the tools that the governments use to implement the drug policies. Drug strategy, therefore, is the document, really written down document with the vision, goals, principles, priorities, objectives, and these are then broken down into more operationalized actions and activities in another document that is called action plan that also ideally includes the responsible parties, timeline and budget for the activities. It's very important to have it written down because to have a written knowledge about what is the actual problem in the country, who are the responsible parties and what are the resources available is extremely important for the effective planning and to be able to translate the thing from a paper into reality. I wanted to say next slide, but it's me now. So what we see in the European Union, currently all the EU member states, they have a national strategy documents. About half of the countries have strategy documents that only tackle illicit substances, and about half, there is now a trend to more integrated policies, so also other substances like alcohol, tobacco, medicines are covered in the strategies, and in some countries that are listed in the brackets, they also include other addictions like behavioral addictions and gambling. policing. There are advantages, disadvantages to both approaches. What's behind the trend to greater integration is the realization that the resources, the responses to different substances and different addictions actually overlap, and also the members of the target populations tend to accumulate problems for one or more problems for the list. Special mention here about the new psychoactive substances that are not illicit drugs by definition, but even the countries that only deal with illicit drugs in their strategies that also include new psychoactive substances, because the risks and also the drug market aspects are very similar to illicit drugs. There's a lot of common characteristics, but also it's important to say at the beginning that the national drug strategies, they differ in their objectives, in the focus and in the content. And this is linked to the differences of the drug problem within the countries, but there's also a lot of historical, social differences between countries, so there's also differences in the strategies. The common characteristics, the one that we think is most important is what we call the pillar model of drug strategies. So there's always two main groups of activities that are content related and that deal with demand reduction and supply reduction. And then there are always three cross-cutting issues of coordination, international cooperation, implementation and evaluation. And it's very important that both the coordination and the monitoring and evaluations are actually embedded in the drug policy documents and they're part of the drug policing cycle. Also, the strategies, they contain a description of the drug situation in the country and of the available services. And here I want to highlight the work on the national drug situation overviews that we did with the Western Balkan countries, but also the EU member states. They write their annual report or workbooks towards EMCDDA, and these are very useful documents because they give the overview of what's available in the country. The coordination structures, how they are organized, they also differ. They're based in different ministries or different governmental organizations. What we see that is effective is that the coordinating body actually has the mandate, has the competence, and also has a budget to coordinate the drug policies. And Portugal is a very good example with a very good drug policy that has been effective over the years, and they have a very strong position in the drug coordination body. Drug strategy evaluation. This is historically the main part of EMCDDA's work in the national drug strategy area. And so the importance of evaluation and evidence-based approach to drug strategies is currently widely recognized. And I mentioned that most of the member states have it actually incorporated in their national drug strategy document. When we speak about evaluation, we mean evidence-based judgment about what we've done and how well did we did it, how the drug policy actually worked. We can also look at what impact it had on the drug situation, but then methodologically it's very complicated to prove the causality. Similarly to drug policies that have many forms, also the drug evaluation programs can be different. They can be conducted mid-term, halfway through the term of the strategy, at the end point. It can be simple progress assessment, it can be multi-criterion evaluation, or it can focus on specific targeted area. And an example of this is cannabis policies, which is a hot topic recently in Europe for the legalization attempts. And it's very important to actually understand how well we are doing with our drug policies and have the evaluation, because it helps us to improve the planning and also react on the changes and improve the services. It helps to efficiently allocate the resources. I'll give two examples where I would like to illustrate how actually the drug policy evaluation is part of the drug policing process and how it helps formulate the new objectives. The first example is from Ireland. It's the Reducing Harm, Supporting Recovery drug strategy that spans between 2017 and 2025. It's a It's a strategy that takes the balanced approach, that aims for healthier, a safer island, and they also tend to improve the harm reduction and well-being of the population. It has 5 main objectives. They have been broken down into 50 points action plan, and this action plan had been evaluated in 2021, halfway through the strategy. The evaluation had 5 components. They started with a simple progress assessment to see what has been done, what hasn't. There was a very broad stakeholder feedback that also included civil society organizations, so they had a lot to say to what's going on and what are the gaps. And then there was an assessment of expenditures. They also looked what changed in the drug situation, looking at the epidemiological data. And given the timing in 2021, they also had a look on what was the impact of COVID-19 on drug services. And the evaluation managed to identify a lot of gaps, including stigma, including vulnerable communities, for instance, also migrants and people that have much more difficult access to the services, and then tried to incorporate it in the new objectives for the second term of the strategy. I'm speaking very fast, no? The second example I want to give is from the Czech Republic, where I'm from originally, but that's not the reason. I will not go too much into detail about the content, because I hope you will get the slides then for reference, so you can also read through it. But it's an example of an integrated approach of addiction. So Czech Republic also includes gambling, cannabis, alcohol, tobacco policies in one document. And they also formulate their drug policies based on the evaluation of the previous strategy, and they also evaluated the first action plan that covered the first 3 years of the term of this actual strategy. What I want to highlight here, and why I selected this example, is that Czech Republic, apart of all the specific action plans, they also have national action plan of the addiction information system. And this is really to stress the importance of the monitoring in the drug policing cycle. So they have a specific document that lists the activities in the monitoring and evaluation, including the key indicators, the routine monitoring of health and security issues, including the TDI registers, the security registers from police. They also set up specifically the working groups on various indicators that also involve the whole variety of stakeholders, including civil society organizations. So I think this is a very nice document to see if you're actually planning your monitoring and evaluation in the country. A few words about the EU drug strategy. I will not spend much time on it because it's now in its 3rd year of validity, but what I want to highlight here, so it has been endorsed in 2020 and will be valid until 2025, and it has also accompanied by an action plan that breaks down the objectives into specific actions with responsible parties. But what I want to highlight, you can download both EU strategy and the action plan from the EMCDDA website or from the EU Commission website. What I want to highlight is the novelty of the language. So it's no longer a strategy against something, but for the first time it's formulated a strategy for something. And you can see it from the aim of the strategy. It's to protect and to improve well-being of society. It's to protect and to promote public health, to offer a high level of security and well-being for general public, and also to increase health literacy. Yeah? So we're not fighting drugs really anymore. It's to increase, it's also balanced strategy, and this is really, historically it was about repression. So now we're bringing up on the same level the public health approach. Yeah? I also want to say it's not a revolution, that there has been a development since 90s where the first strategy of EU was adopted, but now for the first time it's formulated in this way. And it means also like the overall change in the language. So we no longer speak about drug problem, but about drug phenomenon. Yeah? Not about drug abuse and drug users, but about people who use drugs, etc. It's also evidence-based, and this is in opposition to an ideological approach, and it's really based to scientific evidence about what's effective, the proven responses, and about also scientific understanding to the phenomenon. Human rights are at the basis of the strategy, and it also incorporates the gender equality and health equity perspective. About the content itself, I will not go too much into detail. You already know the pillar structure. What is new here is that we have addressing drug-related harm as a main pillar together with the drug demand reduction and drug supply reduction. And this is a very important step, especially and I think civil society especially will appreciate this, because the harm reduction activities are the ones that are coming from the bottom of the approaches, and now they have been addressed as actually the key pillar in the strategy. Yeah, it also recognizes the diversity of people who use drugs, including immigrants and foreigners, and it recognizes the cross-cutting nature of the drug policy and involves stakeholders across various fields. There's also more focus on preparedness now, that's partially linked to the COVID-19 pandemic and to the fact that we really have to be able to see forward and predict what to do. I'm almost at the end. My last two slides actually still are with the two takeaway messages. So just again to highlight that what we see that works in drug policies is when the documents are balanced between the health security approaches, that they are based on evidence-based assessment of the situation and also offer evidence-based responses. They should be a result of consensus, again because of the multidisciplinarity of the issues. There's a lot of stakeholders from the security, there's a public health, there's a security perspective, there's education for prevention, and for the policy to be able to move from the place is very important to have a consensus. It's also supported by operational coordinating mechanism with clearly identified roles and responsibilities, and ideally there could be also budget attached, and it should also support and rely on reliable drug information system. I mentioned that the evaluation is essential for effective policy making, but it's also really important that it's actually part of the policy making process. It's not something that we have to do after the strategy and put it somewhere in the drawer, but should be done ideally on an ongoing basis and actually inform the policy making decision. There is also no single correct way to evaluate. You need to really consider what is the timing, what are the goals, what are the resources. In drug policies, there are always data issues. So you need to plan in a way to be realistic and keep the expectation low. And it's good to start with actually building the evaluation culture with what you have in the first place. EMCDDA is here to support the efforts and to support the national policymakers, especially my colleagues from the support to policy sector. So what we do, we react to requests from the national stakeholders. We support them with evaluation of their policies, but also with developing new policies. There has been also a tailored support on request to actually be involved in the evaluations. We have a lot of materials on our website. I want to highlight the Evaluating Drug Policy 7-Step Guide. I brought a couple of them with me so you can take them, but they can be also downloaded from the web. It's a guide that aims for policymakers and people who are commissioning evaluations, but we also recommend it to use it, have a look at it when you're actually working on the drug strategy document, because the principle for the evaluation, if you want to be able to evaluate drug strategy, then it's good to follow certain principles that are described in the guide. So for this purpose, I think it's very useful. We also have a lot of training materials, and and provide online on face-to-face workshops. There's a dedicated web page. And on the bottom of the slide, I want to point you to an article written by the colleagues from the support to policy sector about their actually real-life experiences from supporting policymakers with their evaluations. And reading this article will save you a lot of frustration, because you will see that the issues that you might be facing in your policy development cycles and evaluations actually are not just your issues, but they're very common, and they are actually inherited and incorporated in the process. So yeah, that's all from us. These are the important links for IPA8 project and policy evaluation, and we'll be happy to answer questions and support you with your efforts. Thank you very much.
Thank you, Katerina. Regardless of war in Ukraine, programs for key populations in Ukraine are funded and implemented. We are expecting an online speech by Sergei Rudoy. He is Ukrainian UNODC National Program Officer. Now we have problems with internet to establish connection with him. We'll try a little bit later. Now I will invite you to join discussion according to data which are presented till now. Yes, Denis?
Okay. Hvala, Đuro. Prije svega, ovo inicijativa iz gledališta.
This is initiative from the audience that after each cluster of presentation we should have a Q&A session. So, to have a discussion after each session, each part of the session, because we have data from the field. We would like to comment this data so that you can understand it fully. And I do feel an urge to express my gratitude to colleagues from Serbia and Montenegro, likewise, who have tackled this challenge, one of the major challenges in the last 10 years, tackled by the civil society, and by this I mean refugees from Russia and Ukraine. Having in mind the incidence of HIV and hepatitis from Russia and Ukraine, even though we get incomplete and inaccurate data from Russia, because they are hiding the actual figures, I would like to express my admiration to my colleagues from Serbia and Montenegro for everything that they've done in their work. This is just a beginning, same as when it was when we first introduced harm reduction policies. Now we have reached a certain level which the state recognizes as well, though not in the proper manner. So before we start describing national policies and state strategies, there's one thing I don't want to hear, that there's no money and that we are looking for foreign donors. We conducted various analyses to prove that money is plentiful, especially in healthcare. However, it is spent extravagantly, and so these services must be financed from national budgets. We do not want to be seeking different funds and asking to bring them into our countries, to include them in our financial transactions without any response on part of the state whatsoever. So people who create decisions on top level, when it comes to strategies and policies and financial responses to different crises, they act really irresponsibly. I can do other things as well, but I have selected this. I want to represent people who have problems with drugs, sexual workers, incarcerated populations and so on, but I want to be recognized. I want this work to be recognized. For Bosnia and Herzegovina, we have brought $50 million in the last 10 years. So only through the Global Fund, $50 million came to Bosnia. 5 years later, not even a cent was invested. All services are closed down in Bosnia and Herzegovina. You could see the result. Our figures are very low. However, the growth of HIV figures has not been recorded ever since the first incidence of HIV in Bosnia and Herzegovina. So, not a problem, services need and work. When our clients ask us, we'll send them to the ministry. So, please, the ministry can respond to, can reply. There is money. There is money enough. So we provided our proposals and we expect true answers. It is not, I'm not trying to criticize people from institutions of Bosnia and Herzegovina present here today, especially as they are here in new roles, which they took only recently. This is a policy which has no order, no analysis of data which is constantly filed to them, nor there are true responses to the crisis. Activists like myself, my daughter and so on, should we be smuggling naloxone treatment, which is not on the list in Bosnia and Herzegovina? That is an ampule that saves lives. Since 2018, we have smuggled, and I'm telling this to the Ministry of the Interior, I've smuggled more than 1,000 ampules of naloxone. Why? Because it is not available in the health system. Well, same way as migrants. I will cross the border same way as migrants. Okay, when it comes to migrants, I would kindly ask you not to be hypocritical, because we also had this big migrant crisis, and there's this migrant route which is along the Western Balkans, which runs along the Western Balkans. We have forgotten about this due to Russia's aggression against Ukraine and the increased number of refugees. But we mustn't, we can't forget people that are still on the road. We are expecting the next wave of refugees next month. Some members, citizens of some states which are highly infected with HIV are also on the road. For instance, people from Burundi and so on. They are not tested either for HIV or hepatitis. We could provide these filters, thus additional services. HIV incidence in Burundi surpasses 60%, so you shouldn't be surprised with these figures. Plus the additional burden of people from Ukraine and Russia, this can be a focal point. This can be a center of the disease because in most countries centers are either at the minimum or totally closed down. So I believe that time has come for everybody to wake up and that we should look for models at top level to respond to such crises. Talking to my colleagues yesterday and the day before yesterday, I got an impression that regardless of the fact that I've been doing this for 25 years, that this is not a topic. Drug users are not a topic anymore.
Kriznim situacijama, međutim, ovo neće tek tako otići, a proizvešće puno veće posljedice.
And this situation will not disappear if we ignore it, and it will generate severe consequences for the overall health system and the society as a whole. So it's high time we turned towards our resources without waiting for investments on part of the international community. So from investments into the healthcare system on national level, if anybody is thinking about the EU as a future donator, I believe that you should forget about this. Within the EU, each member state is responsible for its health system. So there are some small programs at the EU level, but they're just for exchange of experiences. So we should only resort to own resources, but we should finally start using own resources. We have a lot of initiatives in the region. They have been tested, they have been justified. It's only that they need to be adopted and implemented. Thank you.
Thank you, Denis. Dr. Ljiljana Ignjatova.
Hvala, bit ću kratka. I ja sam učila srpsko-hrvatski u osnovnoj školi.
I learned Serbo-Croatian in elementary school, but it was a long time ago, so please do not criticize me if I say something wrong. I have two questions. We have heard about Serbia and Montenegro, that they have activities, that they test, they have free treatment and so on. What I would like to ask is, are these people from Ukraine and Russia included in opioid agonist treatment or just in activities in testing, HIV testing and hepatitis C testing? I'm asking this because unless policies are coherent and connected, if we have something but not something else, that will not be very effective. And secondly, this is rather a common than a question when it comes to naloxone. Do not forget that methadone and ibuprofen are used as well. So it's not rational that we introduce people to methadone and infomorphine if we plan naloxone for them. This is why we should have coherent activities, why we should introduce people to methadone, and people who are not introduced to that, they should also be administered naloxone. But first, the question for Serbia and Montenegro. I have heard that treatment is free of charge. Is it just tick the box, or are people really in the methadone program free of charge? I would comment this in Serbian. I would like to reply in Serbian. It's important that people get the health insurance same as our citizens. They can achieve this by paying a very small amount, let's say 20 euro for insurance, and that's how they get the right to all therapy, same as locals, the citizens of Serbia. So that's how they achieve the right to HIV therapy, methadone therapy, or any other therapy. We insist on naloxone because we don't insist on it because it's still. We insist on it because it's not sufficiently used, same as we insisted on methadone when it was not. much available. In Serbia in 1990s, there was a huge problem because there were no therapies, there were no therapeutic communities, there was not methadone, there were no harm reduction programs, and we were on the drug route. Ever since 2000s, when these programs started, our incidence has reduced. Annually we have 30 to 50 people who die of drug overdose. We've done statistics for the last 10 years. More than 700 people died of overdose in the last 14 years. We believe that this is a missing link so that we could respond to this issue more adequately, certainly at a more advanced level. So that would be also for intravenous users and so on, and some other programs, but for the moment being, I believe that providing naloxone is not an issue. Same as the data on the number of tested. Do you have data on how many of these people are involved in methadone or other treatment? People coming from Russia and Ukraine. So you said that these treatments, that treatment is free of charge if they're registered, but how many people really we have there or not? No, for the moment being, we don't have them. The project has just been initiated with a short delay. This treatment people can get on their own, not only through our organization. We have data within the research needs assessment. We contacted Daily Hospital for Addiction in Theodora Dreisera, and they gave us actually 2 articles of the law. They didn't tell us about the language, about access to services, about availability of services, and how this program is organized for somebody who might not be speaking Serbian. Yes, so, yes, it's tick the box because they can get this service according to the law, but availability and access to this, accessibility to this service is questionable. When it comes to Montenegro, it is rather identical. There's an approach. We have all conditions to provide certain therapy only if they have regulated legal status. If somebody doesn't have regulated private status in Montenegro, wherever they come from, they can have no access to free health services.
Između ostalog, ja ne bih voljela da ono što je meni važno, zbog čega sam se ja sad javila.
Why I took the floor right now. I wouldn't now to contrast naloxone to everything that we already have. It is a complementary program. It's supposed to be a complementary treatment to everything that we have. And in our experience, at least, it has proved, same as in Bosnia. We also brought bottles of naloxone in our packages and smuggled them over the border, and it turned in the field, regardless of the fact that our health authorities were angry, but it turned out that this works. People should have naloxone at home to use it if in case of overdose, Here, Montenegro has no official data, not a single piece of official data when it comes to overdosing. Official data is 0, and we know that in the course of New Year's holidays, there are at least 2 deaths caused by overdose, which are recorded as heart attack, stroke, and so on and so forth. So in these terms, I believe that EMCDDA and UNODC can support us a lot when speaking about this service, Milutin said it's a modern service. I really don't agree with this because this is a very concrete service which has been available in certain European states for a decade, and here it is a modern one. So we should get out of these modern boxes, and we should be speaking only about, or in the context of needs of people who use drugs and who do not want to become a part of any therapy program because that's their right.
Hvala. Sad ja da produžim, ja ću da pričam engleski, pošto lakše mi je da čitam kako piše, pošto mi je prezentacija na engleski. First of all, I will explain situation about migrants in North Macedonia. North Macedonia is one of the central points for transit through the Balkan routes, and an experienced North Macedonia as a transit country and not a final desired destination. The average detention time of refugees in this country is several days only. There is several reception centers in North Macedonia, and two are at the south and east side of the country at the border. One is in Skopje, in village Visbegovo, for asylum seekers, and one is again in Skopje for foreigners. Two transit centers in south and north part of the country are established when the migrants crisis start, and we think that will be temporary, but they remind it. They mainly serve the migrants who will be caught together with smugglers during their illegal entry attempt to the country, and they're kept there in these centers as witnesses in a criminal proceedings against the smuggler, and in some cases this can be accompanied children. Into these centers there is lack of psychosocial assistance, especially for vulnerable population, females, kids, unaccompanied kids. But there is certain type of support provided by a social worker, and what is important, the children staying there are not included in formal education. A reception center for asylum seekers, it's in Visbegovo near Skopje. All persons, regardless their mental status, addiction status, health, are accommodated in the same center, in the same place. There is a rule book written for these cases, and beside other things, these rule books have that stress that individual plan need for every case, which include psychosocial social support, medical care, vocational trainings, involvement in community, and other things. But what is the right to healthcare in the country, related to one document, which you can find on this link if you want to read more about this. Recognize refugees has right to basic health service, and this is again what was mentioned. Tickle the boxes. Tickle the boxes. They have right in Republic of Macedonia, and rejected applicants are covered by Office of UNHCR, but there is challenges. It was mentioned for my colleague, with translation of the language, with understanding language. Transport to the service, it's not covered except in emergency cases. Waiting for documents, they can be offered with document, but they will wait certain time for the documents, so in that period they're not covered. And there is legislation, then they can get document for up to 1 year, but it means 1 month sometimes. And every month they apply, they wait, and they're uncovered. So if you do not analyze the situation, it will look that everything is excellent, but it's not that way in reality. Reception center for asylum seekers at the moment had 60 people, and in 2022 they were about 180 there. On average, most of them, they stay there for up to 1 month, but there is cases that wait for decision even more than 1 year. And from the civil society organization that is present in all these 4 centers, it's Macedonian Young Lawyer Association. They said that there are often cases where people with drug and alcohol dependence come there. And we didn't recognize no one. You will see later that we do not have in a program with methadone. We do not have them in an outreach program. But if you see, if we tickle the boxes, we tickle the boxes. But there is none. There is population, but it is hidden. We can't reach them. We can't see them. And when I talked with the Ministry of Health about this issue, they said we don't have problem. They said stay there a few days and they leave the country, but it's in reality it's not that way. About this civil society organization, which is present, and what is good news for me and for us, they're part of the coalition of 5 civil society organizations, Balkan Refugee and Migration Council, where there is civil society organization from Serbia, from Bosnia and Herzegovina, from Kosovo as well. And this coalition have been established in December 2017, and they collaborate, and this networking is very important because they collaborate also in European Council of Refugees and Exiles. When we talk about the strategy, which is relatively new in North Macedonia, 21-25, before we write this evaluation, we used several documents. One of them was supported by UNODC related to quality treatment standards. And when we make this document, we find that regarding the principle 5, responding to the needs of special subgroups and conditions, we find that country has not specific service for females, for kids, not mentioned about refugees. And we have some specific services for kids, for women, for sex workers run by civil society organization, but not for refugees. This is hidden population in my country. But it's a good news that this civil society organization, Macedonian Young Lawyers Association, is present in these 4 centers, and they offer legal aid. So probably after this meeting, we will contact them and we will think what we can do about this together with other civil society organizations different hopes which are present together today. Another document which we used before writing our strategy was results of substance use disorders treatment facility survey, which is again supported by UNODC, and this is about data that we find for 2019, and you can see here number of vulnerable population that are served, that are receive some treatment in 2019, and there is not refugee here at all. There is LGBT population, there are pregnant women, Roma population, and other, but not refugee, as we don't have problem with that. Before this new strategy, we, as Katerina mentioned, evaluation is very important, and we did evaluation before we write the strategy, and what we find. The evaluation was run by civil society organization, Healthy Option Project Skopje, and the relevance of the strategy, last one, 2014-20, was very high. But impact was rated insufficient, and about implementation, it was partly implemented. And you can see table here about action plan, 2 action plans, a percentage of partly, fully not implemented or ongoing activity. In this evaluation is stressed that the reason for weak implementation is that we who write the strategy, we are very ambitious because we understand the problem. We are aware of the problem, but it's not case with decision makers and political will and interest. It's big discrepancy. We will write everything nice at the paper, and maybe it is for us optimum, but it's not optimum for a decision maker. And another reason for implementation, lack of implementation, is transfer of responsibility from one to another ministry. For example, Ministry of Labor will say, Ministry of Health will do it, Ministry of Health will say, Ministry of Labor will do it, and no one will do it at the end. And coordination and regular reporting of degree of implementation is missing, so we can't stress that implementation is not going on. About national drug strategy, we analyze the problem and needs before we write new one strategy, and thanks to treatment program for opiate agonist treatment, harm reduction program from civil society organization, and access to antiretroviral therapy, we have very low prevalence of HIV. And in last 10 years, there have been only 2 new HIV cases in last 10 years, no new cases in last years, and but it is not case with C hepatitis, which show us that risky behavior is present in this population. New national strategy stress that program for treatment of people with substance use disorders need to be adapted to, towards specific needs. It has balanced approach, what was mentioned, demand and supply reduction, but one significant challenge is lack of financial resources for implementation of drug policy, as well as will and interest of decision makers. The strategic priority, I will not talk about that. It's like European strategy and probably all other strategy, but strategic objectives are effective system of drug prevention, a good quality program for treatment, inclusive of all people, harm reduction program that are improved, suitable, and adjust to the needs of users, tailor it for specific groups. I will finish with this slide. The national drug strategy is based on the premises of protection of human rights, security of all citizens, equal opportunity, equal and balanced access to citizens, and should cater to the needs of different target groups, shared responsibility and coordinated access, and of cost efficiency. Thank you for the attention, and I will be happy if there is some question for me.
Short.
Ne radi. Evo ga, sad proradi. Koliki je budžet za
What is
provođenje?
the budget to implement this strategy? What's your budget?
Budžet za strategije od 2017.
The budget for from 2017 has grown, but some improvements have been reduced because some patients were left without their treatment, but we had a problem in harm reduction services, which had a reduced budget, and that was mentioned in my presentation as well, that the budget was reduced. It used to grow from 2017 to 2020, but the previous period encountered some reduction. What is a major challenge is fast changing of ministers in the Ministry of Health, and that we always start from scratches. We start working with new ministers, and we have to explain what is addiction, whether it's a disease, whether it requires treatment, and then another minister comes, and we have to start from the beginning. So for 30 years, I have been doing this first lesson about addiction. I have no chance to give them the second lesson. If the strategy is not part of the budget, if it is not based on grants but on budget, it is very hard to succeed. Long time ago, I told my colleagues from Macedonia that what they made after the change of government, they got all the budgets increased. I told them that it was just a political phase. Now you see that this is not a systematic measure, but just returning to some confidence in civil sector, but nothing has changed radically. All other countries are in the same situation. There are no systemic responses and no funding through budget. For 100 times I have repeated, and I want to return to that. This is not just the budget of people working in institutions. They did not give you anything. It's your budget. You have been chosen to manage our mutual money. It's not something that you have been given. You have to manage budget. So we have to change the public discourse. This is the money of the citizens, and that money is ill transferred for the needs of those citizens. I agree with you
governmental organizations suffer from
governmental organizations suffer from that issue as well.
We can't compare when Global Fund was in
Mi možemo da menjamo to,
we come back
možemo da se vratimo nekoliko koraka vezano za lečenja vlade. Nema više supervizije, nadzora, nema obrazovanja, nema kontinuiranog. Znači, samo zemlje ne preuzimaju nikakve aktivnosti koje su se, znači, lečenja na koje samo lečenja koje organizuju organizacije civilnog društva. Znači, to se odnosi ne samo na civilno društvo, nego i na vladine organizacije.
No interest, not interest for this, like drug addicts, it's not their interest. So they're on the margins of the margins. First are maybe cardio surgery and whatever, but not drug addicts. And this is big stigma, and everyone are stigmatized. And we should be complementary, governmental and non-governmental organization. We should advocate for both, not only for governmental or not only for civil society, because we are on, every one of us are in same sauce, in same situation.
Okay, we have a reaction from Healthy Observance Skopje. Hops, please take some microphone, maybe to Denis, yeah?
U redu. Pričat ću i ja srpski, zato što tako mi je lakše da se izrazim, iako nije moj maternji jezik.
Although it's not my mother tongue, but I went to school and taught, and I studied Serbian. Thank you for this round table. It's good to know the share experience in work with immigrants, which Milutin presented. Why I wanted to speak. My previous colleagues, Jan and Milutin, mentioned the most important thing, but what I want to say to the UN ODC colleagues and Global Fund colleagues and other organizations is that Macedonian example Macedonia was the best regional example of good transition. It was a convenient political situation for us, but and last year, due to political situation, we practically, we were a regional example which can turn over and become a very bad example. So, government changed in Macedonia last year, new prime minister, new minister of health came, and we were cut out, and we lost communication with the institutions. And previously we had good communication with them. Then we lost not only increase of finances for prevention of HIV, for 10 settlements and harm reduction programs, but we also got reductions which affected civil sector because the percentage of decrease of the activities implemented by and who are implementing harm reduction And even this year, in the budget for 2023, that was adopted by the Parliament and proposed by the government, this is the highest budget that Macedonia as an independent country ever had. I don't know where they will find that money, that put it on the paper, and that budget has the lowest percentage allocated for health and for the Ministry of Health. And then, in that budget, they hardly found 150,000 euros, which is 9 million dinars, less than 10 million dinars, for prevention of HIV. The program has been published in the official gazette. There is no announcement yet. 2 months have passed. We are not financed as organizations, but not even a big organization can survive it. So the figures that Milutin presented will be reduced to 50%. If we had 16 programs, that program is reduced to 14, 12 programs. Now we expect that this year it is reduced to 7 or 8 programs because smaller organizations declared that they could not have that survive on such small financing. Last year they allocated 500,000 dinars for HIV people for the whole year. I want to underline that last year we have worked campaigns and we contacted all UN agencies and representative offices in Macedonia. Unfortunately, we were supported only by the European Commission, who in their annual report stated that they are very worried about this reduction, and they recommend the state to increase. But the UN organizations during the COVID pandemics who were in charge, we did not get even logistic money. We asked for support to influence our politicians. They didn't want to talk to us. They didn't want to organize meetings. We did not have any communications with the Prime Minister and his cabinet, so we could not represent them, but we had campaigns. What I want to have as a recommendation for all the institutions is that if we really want things to move, at least in this region of Western Balkans and former Yugoslav republics, we need to jointly share good practices. I'm glad that in Serbia things are moving forward, and there are lots of things that have to be done. And as for the strategies, we expect support for strategies. At the end of 2021, we have made strategy which was mentioned, and it was in line with EU strategies. So it was adopted. We waited for the European strategy to be adopted to see how it worked, and we did not, it was not allowed to us to do budget that will be included in the state budget, because the Ministry of Finances, if you want the strategy to be adopted, if you want it, it has to be without financial implications. You cannot get everything from abroad, so but government has to have some implications, and I fully agree with Dennis. We need to apply to support our focal points, to do midterm evaluation, the evaluation of the first action plan, which was almost close to zero, because for 1 year we, at the beginning of 2020, it was 2021, it was national strategy was adopted, and then the government changed immediately, and for 1 year we have done nothing but change the criminal code to be to treat illegal possession as that cannot be treated as criminal act. Nothing else from the strategy has been adopted. We ruined what we had planned. Thank you for giving me this opportunity. I believe that we will have... I don't know whether there are some other representatives of the fund. I'm glad. We applied to Global Fund. Unfortunately, we did not get any feedback from them regarding the support that we asked for to support us in fight for the Prime Minister and before Prime Minister and government. To give explanation how important this is to be sustained. Maybe with Global Fund, if we don't have financial aid, maybe they could provide us support in representing us before the state and the government in order to survive. Thank you.
Thank you, Heidi. We'll continue after the break for half hour at the noon. Let's to start. As we announced, our colleague from Ukraine, Sergei Rudoy from UNODC, he is a national program officer, will have speech through the online.
May I? Hello, colleagues. I'd like to welcome you on this round table, but I do not know how to present my PPT from the PC. Possibly the organizers may help me. Okay, Okay, as you know, the strategies is a common document for any kind of the organization, and UN is acting in the common line with others. We have the strategy for sustainable development, we have UNODC strategies, we have strategies for the HIV, for tuberculosis and malaria and others different strategies, and we trying to align those strategies with sustainable development goals. And next slide, please. The first slide there is saying it is not convenient. Yes, that one. And Commission on Narcotic Drugs promoted and advocated all the countries to have their own strategies how to deal with illicit drug trafficking and how to deal with other narcotic drugs related issues, and ask to develop their own strategies. The next slide will show the very short excursion to the, for example, the USA National Drug Control strategy, which divided on different chapters, like for the different part of the country, and for different compounds, different medicines or illegal drugs, for methamphetamine or for cannabis. And this is a quite good example how to develop this strategy. Next slide will show you the Ukraine's steps in drug strategy development. We started since 2012 with the National Committee on the Narcotic Drugs Control, and that was the first idea to develop national drug strategy, and UNODC program office in Ukraine, together with the Ministry of Health, with National Committee on Narcotic Drugs Control, with Ministry of Internal Affairs, national and international NGOs, and other partners. Altogether, there was about 300 and a half participants in that, and many officers from the UNODC headquarters were attended the meeting as well. We IMA UNODC office in Ukraine conducted the international high-level conference on building a new strategic approach on the drugs. And this conference has resulted in first national strategy on narcotic drugs from 2013 approved by the government, but due to different reasons, especially due to the rapid change in Ukrainian society and revolution of dignity, and in the war, and changing in the Ministry of Health, changing in the Ministry of Internal Affairs, and completely new approach to the public governance and the health system reform. That strategy from 2013 was not implemented in full and just started to implement in 2018. The same time, Ukrainian office conducted three consecutive international conferences, regional conferences, toward the drug strategy, and in these conferences we tried to gather people from the region, from decision makers bodies like government, like national parliament, like international organizations, to share their ideas, their vision on the drug strategy, on the actual state of drug use, drug treatment, prevention, rehabilitation programs in Ukraine, and try to advocate the common vision and integrated approach to the strategy. The last conference was in 2021. It was the COVID time, and we did that conference online. But last year, I mean 2020, 22nd, we have no chance to do the conference. But all these conference and advocacy efforts were complemented with, next slide please, were study visits. There is only 2 study visits on the slide, but we had about 10 study visits for the different levels officials to Czech Republic, to Italy, to Germany. We were visiting Lithuania, we were visiting Moldova as well to exchange our experience and ideas. And we brought together people from the Ministry of Health, from as well Ministry of Interior, people from the Parliament, people from the Ministry of Economy, people from the Ministry of Justice, and specifically from the Prison Department, to give them new ideas, to fresh air and new eye on the situation. What is the position in different countries? As well, that was very fruitful visit to the EMCDDA, and it was like no return point for our officials to go ahead with the strategy development. And next slide. Since 2019, Ukrainian office did at least 3 major training events for the decision makers about the nature, prevention, and treatment of drug use disorders. Here on the slide, you may see the main topics, and first event in 2019 was offline in-person event, brought together about 70 people, and we spent 3.5 days presenting UNODC approach and UNODC training materials, discussing a negotiation of different approaches. And then we were requested for 2 separate trainings, first for the internal affairs police officers, police departments of anti-drug, for the prosecutors' offices. And the second event, additional event, was for the prison staff, especially for WAS prison, where substitution treatment is already implemented together with harm reduction services. So my vision that all these in combination have moved the idea and thoughts of the governing bodies and decision makers towards the strategy. At the same time, next slide, the situation with drug use and drug-related offenses not so I would say so bad as in other countries. I would not name the country, but we looks quite peaceful in this situation, with quite good developed OAT treatment, opioid agonist therapy, and on this slide, OST patients about 14,000, but in actually now we have up to 24,000 people. Despite of the war, we have very low withdrawal rate and quite good supply of the medicines, and people may have, even in this time, people may have take-home doses for 10 days and quite good operational treatment protocols and treatment standards. So the situation looks like quite peaceful, but growing number of new psychoactive substances makes us a little bit nervous, and big variety of the substances available on the market with a difficult situation now and in previous year made very good ground for the government, for the international organization, national NGOs to sit together and think about the strategy, considering that previous strategy from 2013 till 2020, which was not implemented in full, frankly speaking, with very low implementation rate. We need new strategy by 2030, like in line with Sustainable Development Goals. Sorry. Ukrainian office submitted proposal to the Ministry of Health, to our partners, and we made the working group under the order of the Ministry of Health with national, international NGOs, different ministries. You will see the last slide, not the full composition, but from the big layer of the players on the ground. So we developed a draft of the strategy composing of 4 strategic goals with different numbers of operational goals inside. All operational goal has exact activity we have to do, and in addition to the narrative of the strategy of the national drug strategy, we drafted the implementation plan for upcoming 5 years, but the war forced us to postpone all the activities, and the strategy still in the form of draft, and I suppose after the war it will be updated regarding the situation for that time. So anyway, for now, the strategy consists of the strategic goal 1, you may read the name, and operational goals. Next slide, please. Strategic goal 2, narcotic drugs, psychotropic substances, and precursors, illicit trafficking, counteracting. These more like law enforcement activities regarding drug control, drug demand reduction, drug use prevention, and fight with illegal markets and illicit laboratories, illicit producing. And the strategic goal 3, please next slide, is for the medical system and for harm reduction activities and secondary prevention as OAT treatment, buprenorphine and methadone treatment, different types of addiction treatment with psychosocial activities, psychotherapies, etc. And separate part here is palliative care development. This was specifically from the Renaissance Alliance, and we agreed to support that, but the Ministry of Justice recommended us to remove this goal as they think the chapter is not suitable for the drug strategy. I'm not sure they are correct, but that was proposal. And the last strategic goal, timely and quality assistance to people with mental and behavioral disorders due to use of psychotropic substances. which means development of the standards and comprehensive approaches for the medical and psychosocial support, and both systems, social support and healthcare systems, to be open and compliant with needs of the patients and with the evidences from the research and international practices. Together with operational goal 2 under the strategic goal, improvement of the treatment system composition and provision of good services by decriminalization, a reduction of stigma, and an introduction of alternatives to imprisonment. That was very innovative moment for the time we developed the strategy, because issues of decriminalization still are quite acute for Ukraine, quite sharp, because of some figures in 10, even in 100 times less than even in neighboring countries with more stronger regime. So the last slide, almost last slide, the continuation of strategic goal 4, introduction of treatment in prison and setting up the effective surveillance, that was in full compliance with any normal program or project document, with very vital part of the monitoring and evaluation, and we agreed with the partners that the strategy shall be updated in 5 years upon the results we may have after the implementation. And next slide, you may see the national counterparts participated in the development, in the drafting of the strategy, but the whole government and all regional administrations in Ukraine, these are like local governments, were reading the strategy and providing their feedbacks and recommendations for the strategy. So this is quite big document with quite long history of development. Thank you for your attention, and please keeping safe. Over.
Thank you, Mr. Radoy. We wish you well and safety, and the war ends as soon as possible. You found the gifts. Yeah, you find the gifts on your tables. That are some mugs. Yeah. When you pour something hot into them, you will be able to remember this round table. The next speaker is Miss Andija Meksi. She is a harm reduction and drug treatment expert from Albania.
Thank you. Can you hear me? Okay. Just to clarify, I work at the Institute of Public Health in Albania, and I'm very glad that you invited me to present an overview of drug policy in Albania. Can we have the presentation slides, please? So currently Albania has not a problem in relation to providing harm reduction services for Ukrainian refugees in the country. We had very small numbers of Ukrainian refugees, but they were just transitory, and then they traveled to other European countries. We had, for several months, actually, we provided shelter for people fleeing from Afghanistan. And currently we have a very small percentage of them, because they have already, most of them have already traveled to the US mainly, and Canada, So we provided shelter and also other health care for these refugees. So my presentation is going to be mainly on the current policy framework. So what are the laws and strategies that we have incorporated the drug treatment, and then just want to provide you within the slide an overview of the institutions and treatment services that provide drug treatment and drug harm reduction programs in the country, and then briefly just an overview of the drug use situation in the country, and then what are our future steps and plans. So Albania doesn't have a national drug strategy, as I heard from Montenegro, or if I'm not mistaken, but nevertheless, we have some strategies in place that has incorporated drug treatment. Our main drug strategy, for example, is the National Health Strategy 2021-2030, which was approved in April 2022 and is an umbrella strategic document in the field of health, and it foresees specific objectives and intervention related to promotion of healthy lifestyles and ensuring a healthy environment through the strengthening on intersectoral cooperation, the development and strengthening of policies and action plans for alcohol, drug and illicit drug use. So within this national health strategy, we are planning to develop quite soon a national action plan on harm reduction intervention. Another very important health document, strategic health document, is the Health Promotion Action Plan 2022-2013. Within this strategic health document, we have specific objectives and activities related to promotion and prevention of drugs and drug-related harms. Another important one is the National Program for Prevention and Control of Non-Infectious Disease, 2022-2030. This document, also very important, it is a document that specifically emphasizes the need for harm reduction programs in the country and the continuity and sustainability of harm reduction programs in Albania. So as you can see, we already have 3 or 4, we also have the National Action Plan on HIV/AIDS 2020 and 2025. So these are our main strategic documents in the country that covers a specific aspect of drug treatment. Beside the drug strategy, we have an important law, which is law number 7975 on narcotics and psychotic substances. Currently, this law is being it's outdated. There are specific list of precursors and psychotropic elements in the list that are, let's say, allowed it and not, that is being revised. So the Minister of Health is now revising this important law and dating it in accordance with the conventions, UNODC conventions. And another important law is the public health law. We have another specific, let's say, decree from the Council of Ministers that emphasizes the approval of functioning of a National Coordination Committee on War Against Drugs, Secretariat of the Committee, and the Office of the National Drug Data System. So basically, this is let's say, Council of Ministers decree specifies the roles for the National Coordination Mechanism against war against drugs, and also of our National Office on Drug Data System, which is within the Institute of Public Health. And we, in 2019, we had the clinical guidelines for the provision of methadone maintenance therapy developed. So as I emphasized, we don't have, for many years now, we don't have a strategy on drugs, but the Ministry of Health, and in the past years, because of the situation in Albania in regard to the problems with fighting the cultivation of cannabis in the country, the government focused mainly on one of the main pillars of the strategy, which is fighting the drug supply. So, and in the past years, the drug demand pillars has been, let's say, non-existent. So the Ministry of Health has decided to develop a new action plan for the prevention, treatment, and reduction of drug harm, which will specifically address the objectives related to provision of harm reduction programs in its own services. So as I said, we will definitely, we are currently just beginning the process of revising the whole EU drug strategy and action plan. So our document will be based on EU and other relevant international documents. So this is just to explain in one slide what are the main institutions responsible for drug prevention, treatment, and care, following care in the country. As you can see on top, we have the Ministry of Health and Social Protection. They have, on your right, they have a General Directorate of Health Policies, and we have a person who is, let's say, actually now the place is vacant. We don't have a specific expert on substance use disorders, but there is still a place within the Ministry of Health that is responsible for drafting policies, drug policies in the country. And then below we have the Institute of Public Health, which plays a really important role in not only prevention, research, but also providing harm reduction programs. It's within the Department of Communicable Diseases. We have the National HIV Program. They also have a monitoring system within the IPH for communicable diseases. And also IPH plays a role in providing harm reduction programs, monitoring the programs in the country, and also, let's say, diagnosing cases for HIV and other communicable diseases in key population, drug use key populations. And as you can see below, there is the Office of the National Data System for Drugs within the IPH that mainly collaborates with MCDDA in order to improve our national drug information system. And then we have also other institutional in place. Below, we have the University Mother Teresa Hospital Center. It is very important because beside the civil society that provides opioid substitution treatment services, we have the only public hospital-based addiction treatment center within the Mother Teresa Hospital Center. They have full-time doctors there and 9 nurses employed. And then we have, as you can see, there are other institutions that are important and are also, let's say, coordinating with the Ministry of Health. We have Action Plus, which is a very important organization that provides methadone maintenance treatment programs in the country. They have 9 centers and around 900 patients. And then we have the needle exchange program. All these services, the harm reduction services, are provided by Global Fund. So the Ministry of Health coordinates with the Global Fund in order to, let's say, coordinate and then monitor the harm reduction programs. As Albania, so how do the health system in general, we have the National Compulsory Health Insurance Program. So any person or resident who is in Albania has to, let's say, have the rights for to get health services free. So this is also through the national compulsory health system, we have the prevention, treatment of not just drug treatment, but any type of health problems. And then we have the prison system, which they collaborate with Action Plus, and we have something around, if I'm not mistaken, 100 people under methadone treatment within the prison system. So this is just, I wanted to explain how the institutions, mainly through the Ministry of Health, coordinate in order to, let's say, implement the specific objectives, strategies we have. So what we are trying to do is that to include all these services and those who are not primarily, let's say, integrated within the interventions, drug treatment interventions, such as, for example, the National Compulsory Health Insurance Program. This is some data in regard to the latest survey we conducted on children and young people. This is from the Health Behavior in School-Age Children survey in 2017 and 18. The latest data we have on SPAD is from 2015. The 2017 HBSC study shows the lifetime prevalence of cannabis use among children is 3% among girls and 30% among boys. The European average of cannabis use is 15 for girls, 15 for boys and 11 for girls. The SPAD study in 2015 showed a prevalence of 7% of cannabis use among 15 and 16 years old. This is some latest data we have in regard to the extent of illicit drug use and dependence. In 2019, IPH conducted a biological and behavioral study with drug users and estimated number of people, of IDU people, is around 7,000. And the rest of the patients, let's say, that have requested treatment for their substance use primarily is 913 on heroin use. And then the rest of the patients, 443 that were treated in Mother Teresa Hospital Center, were primarily for cannabis, cocaine, and heroin use. So what are our future plans? Well, first of all is to develop and proper adoption of the action plan for prevention and treatment of reduction of drug harms 2023-2026. We'll specifically focus on the improvement of prevention, identification, and referral of primary health care level through the health promotion and psychosocial health care workers established in primary health care services in Albania. We aim to extend and improve our existing treatment services, drug treatment services, and focus on the integration of psychosocial intervention and continuity of care. Within this document, we have to discuss and specify the harm reduction programs that are currently in place. So the idea is, the proposal idea will be that the harm reduction program will be mainly or co-funded by the Albanian government through the Ministry of Health and through the National Health Compulsory Program as a dedicated health budget with a global fund, but this is still to have to be discussed. So the idea is that the National Health Compulsory Program will take over, let's say, or will be responsible for funding the harm reduction programs. Thank you.
Thank you, Ms. Maxi. Our next speaker is Mr. Dragan Vukadin, Ministry of Security, Division for Suppression of Misuse of Narcotic Drugs from Bosnia and Herzegovina. Mr. Vukadin.
Hvala. Dragan Vukadin iz Ministarstva sigurnosti,
Ministry of Security of Bosnia and Herzegovina. I'd like to thank for inviting me today. I'd like to thank my colleague Milosevic, and I'd like to thank all of you who came today and for this active participation in a round table. I regret that my colleague Daniela was not here. She said that round table is used for everyone to argue and that we feel great after that. But the only thing that I felt from my colleague Denis, who comes from Bosnia, and his words that were directed to us as a state administration, but it is not personal. We are representing institution. He's representing NGO. I'm from the ministry. You've heard him. I'm relatively new in this position. I'm trying to attend meetings, seminars, and maybe I will always try to get involved or get someone else involved in such events. When Mr. Milutin invited me personally, when I started to get ready with the data, I saw where we were, because I understood that we need to have representatives of entities, Brčko district, and together with Milutin, we have agreed that 4 people are here from the Republic of Bosnia and Herzegovina. I'd like to remind you that we are such a complicated country, so we have 140 ministries, don't get faint. So 140 ministers, 140 assistant ministers, 140 vehicles times 7 counselors of the ministries, and all that. So when there is someone like me to try to gather data, to lobby something, and to coordinate something and present something somewhere, it would be much easier to build a nuclear power plant than to gather data. So have in mind, when we are talking about Bosnia and Herzegovina, we are improvising, we are trying to work, and all criticism is welcome. What Denis said is the only way to make progress. I like when I'm pointed out to such things. I'd like to respond to Denis. I want to remind him that I have initiated in 2022 a meeting with the minister, between minister and NGO, and minister told me that he is leaving, and new minister came 20 days ago. Immediately I went there and I said, people from NGOs want meeting to point to the things that are important: budget, financial aspect, coordination. That was not present in place until now. And they told me it's not a problem, the minister has just been appointed, so I believe that in March we will have that meeting organized. I will not talk about the data, statistics. My colleague Vedran will give you that part of presentation, but I only want to underline that we are in a particularly bad situation. When I came to this office in April last year, I was full of energy, enthusiastic, and I could not understand the word nothing can be done. I understand that I cannot go to the moon, but And nothing is impossible. Strategy is not existing. It's from 2018, it's up to 2023. No action plan has ever made from that strategy that speaks that we have not managed to rise from the zero position. Something has been done in some parts of Bosnia. Federation, there is lots of space but since we are at the zero position and there is space to do something. The major challenge for us, since we are starting the drafting of new strategy and action plan, is how to inform and persuade decision makers and how to lobby them that we are not doing the strategy related to drugs, but strategy related to all forms of addiction, as the tendency in globally is. So strategy and action plan, how this will look in future. I ask you kindly to see me as someone who is coming from state ministry, and I'm close to the source of flame, so to say, and not to make the strategy related to drugs exclusively, but to do strategy against all sorts of addiction, pornography, online gambling, alcohol, cigarettes. And what is my plea for assistance? I talked to Sanja from Croatia, how Croatia made the strategy. This is a good way. This is an excellent input, especially from the colleagues from EMCDDA, is to make the strategy related to all forms of addiction. Because, as Denis mentioned, drugs always existed, but there are some new things coming in focus. In 2023, we are not going to talk only about drugs. When's the time to talk about alcohol and cigarettes? Alcohol is even worse than drugs. Practical solutions, decisions, suggestions. Please contact me, send me anything, send me a document, send me a link, send me an idea that has not passed in your country, but maybe will be. That would be the best outcome of this event for me. I kindly ask my colleague Vedran, who comes from the Federal Ministry of Health, to give you the details that we have at the moment from that particular level. Thank you.
Dobar dan svima, Vedran Arčinko, Federalno ministarstvo zdravstva.
I come from the Federal Ministry of Health. My name is Vedran. I come from the Federation. I will refer to that part, that territory. When we talk about federation, when we talk about migrants and the population we encountered in the last couple of years. We have 6,000 to 8,000 migrants at all times coming from Middle East and Africa, Pakistan as well, Far East. And as for the Ukraine and Russian migrants and refugees, let's say, due to war, we have 1,200 Ukrainians who contacted the healthcare system of Bosnia and Herzegovina. So it means children who had some needs as for protection from flu, COVID-19 protection. So we know that 1,200 have been here for 3 or more months. We gave them longer residence. They are fully covered health protection. As to HIV cases, we did not have any persons from Ukraine with that problem. Our organization, Partnership for Health, cooperated with NGOs from Ukraine, and every day we are in contact, but we still did not have such cases. But migrant population coming from Middle East and Africa, we had 8 recorded cases of HIV positive persons or HIV infection, and we managed to detect, we provide them testing, counseling. We rely much to NGOs because they get better in contact with migrants, because migrants tend to avoid administration, and I'd like to thank the NGOs and Partnership for Health primarily, who contributed much in this crisis. And we have allocated some funds from budget, 100,000 convertible marks, like 67,000 euros annually for prevention and therapies. This is to be implemented in Tuzla and Sarajevo cities. We also have a center for prevention of addiction in bigger cities like Zenica, Tuzla, Sarajevo, and Mostar. And that reduces harm as for addiction, drug addiction. So these persons, addicted persons, are less prone to crime if we prevent them and provide them that kind of treatment. 2 months ago, we made education for 16 new healthcare workers who are trained for voluntary testing and testing against HIV. And that's what we have in Federation. Thank you very much.
Kolega Đurasović, ako može samo, evo je kolegica Sanja se javila iz nevladine organizacije Viktorija iz Banja Luke.
We have our colleague Victoria from Banja Luka. She would like to...
Nemam ja problem da sačekam, ja svoj red uvijek dočekam. Dobar dan svima.
I can wait, but hello everybody. I'm really glad to see you all and to greet you all. I'm glad that I'm here at this distinguished conference where I see numerous distinguished professionals, so I would like to thank organizers of this conference. I have an urge to say, same as Mr. Vukadin, I'm the executive director of Victoria NGO from Banja Luka. We've been operating since 2002. And I have about 20 years of experience in this area. We tackle addiction, illnesses, which is drug addiction as a topic, and I've been a member of this since the very establishment. And this is why I believe that I should have a say in this. I'm always rather optimistic, so I would take this course. In the very beginning, this seemed to be rather confusing and frightening when Mr. Vukadin said 140 ministries. We are not that large a country. Bosnia and Herzegovina comprises 2 entities, Republic of Srpska and the Federation of Bosnia and Herzegovina, and Brčko district. In the Republic of Srpska, the system is rather simpler because it's centralized. We have one ministry each. We have one ministry each. We have one commission for curbing psychoactive drugs and so on. We have one president each and so on. So what makes this situation complex is that we all need to function according to our competencies, both internally and externally. So for a country to function responsibly and to treat such an issue responsibly, we know that it's important to have legal framework, strategic documents and mechanisms for implementation in place. Certainly it was possible to hear in several discussions, unless there's a system of financing, all services that will be provided in multi-sectoral manner will not be possible. So there will not be a mechanism for implementation. At least for us who are in this area along primary lines, we cannot resolve this on our own. The non-governmental sector cannot do without the government, and so on and so forth. In Bosnia and Herzegovina, it was already mentioned, when the Global Fund program response to HIV was implemented, things were going fine. There was a system in place, a systematic approach was taken, and it was supposed to continue because 10 years of experience, work aimed at all populations, numerous investments in human resources, and of course you know that human resources are the key to everything. There are not many of us who deal with this area, and mostly in the course of their specialization, colleagues will not treat drug addiction and drug addicts. Why? Well, because this is very hard to get any results in this area. The results are really far-fetched. Whereas a surgeon performs a surgery and the result is visible all of a sudden. Well, as my colleague mentioned, in Bosnia and Herzegovina, strategy is from 2018-22, so it has expired. However, we know that strategic documents are the backbone of any future work. So the Council of Ministers of Bosnia and Herzegovina in 2007 established a committee for curbing abuse of psychoactive drugs, featuring representatives of the ministry from the entities and Brčko district. The composition was further extended with representatives of the Ministry of Finance, Ministry of Interior, Ministry of Justice of Bosnia and Herzegovina. So in practice, the Commission comprises, the Commission convenes 2 or 3 times in the course of their 4-year mandate. So where do we put responsibility here? Is the responsibility up to individuals or up to Bosnia and Herzegovina? The Commission is to report to the Council of Ministers and entity governments. It hasn't been done, however, since the establishment of these bodies, following the adoption of the strategy and the action plan for Republika Srpska 2008-2012. The government of the Republic of Srpska was obliged to establish the Commission for Curbing Psychoactive Drugs. It's been functioning ever since. As I told you, I am a member. The Commission comprises 13 members, NGOs, inspectorates, governmental organizations, parliamentary board committees, and all the things are done in multi-sectoral manner. It is important to emphasize that the decision, well, by passing the state strategy of Bosnia and Herzegovina, this made an obligation, this provided an obligation part of the entities to pass the same strategic documents So don't take me wrong, but this is really irresponsible on part of one entity. I don't want to praise one and criticize other. I don't want to criticize anybody, but we need to address this to ourselves. Why is this not a priority? And issues are really getting more and more intense. Well, prevalence is low and under control. If the situation with the lack of financial support continues, if we cannot service our activities to key populations, and let's be honest, migrant crisis is present, occurs in Bosnia and Herzegovina, but in case of some other crisis situation, so what would be the response? We do not have a proper response to the population that we are faced with already in Bosnia and Herzegovina. As importantly, regardless of the Global Fund program, the program of new psychoactive substances has been mentioned several times. We in the Republic of Srpska urge that the list should be complemented. It hasn't been complemented for 12 years. These are but key issues, and I want to finish with this. There are some of us who know what should be done. We don't need, and I'm saying this in my own name, and I believe this is also the position in Republika Srpska, we don't need guidelines how we should work. We should find out how to find financial and other mechanisms. We are all familiar with the issues we are faced with. Mr. Hren, much distinguished sir, I am glad to greet you here. You have contributed a lot. You have done evaluation of the strategy in Bosnia and Herzegovina with my colleague, and you provided very important key recommendations as to what needs to be done. So it's important to do the evaluation, but as it has been mentioned several times, we need to find finances for all programs from within. After the program of the Global Fund, the state was obliged to allocate certain funds. The Republic of Srpska has received 15,000 marks from the 50,000 on the level of the whole republic. What do we do with that? We can't even work with that. We need to do certain things within. We need to find mechanisms how to do that. Do we need to exert pressure? Well, I wouldn't go there. I mean, it needs to be discussed. Are there any funds? I'm certain there are, but they need to be streamlined the proper way. Strategies are perfectly drafted. I participated in the drafting of the entity strategy and the republic strategy. But unless funds are planned adequately in line with priorities, we'll be jumping from an issue to another. So I wouldn't like to go into any more details. I just wanted to share this very valid information with you. Thank you.
Thank you, colleagues from Bosnia. Now is time for lunch, and it will be half of hour. We'll continue at 13:35. Dear colleagues, time to continue. We are an hour behind schedule. There are 7 speakers left. I will ask following speakers to be concise and present up to 10 minutes per country so that we can finish on the time. We have this space to the 3 p.m. Because of that, we need to be short and concise. Our next speaker is Sofia Kastratović from Ministry of Health, Montenegro. Sofia.
Dobar dan, hvala prije svega na pozivu, zaista je velika čast
Thank you for
biti
inviting me. It's a great honor to be here. I'll be very accurate and concise. Essentially, as a ministry, we had 2 years of empty space, and because the previous strategy was made from 2030 to 2020. It was planned to do last year we planned to do the new strategy, but it was postponed for this year. As in many previous cases, the situation is very similar, and numerous changes in the government postponed the whole process. And we had a very big problem with cyber attack, which is ongoing, and it has lasted for 7 months, and it's still ongoing. So the strategy will be made until the second quarter of this year. We're following all the guidelines of EMCDDA and UNODC. And we included the research and international cooperation fields, and what was a big problem, intersectorial cooperation. So the focus was on networking of all stakeholders in order to make a coherent whole which would function adequately. We are aware that that is a crucial document necessary for further activities, and criticisms and comments that we are taking them into account. We will continue cooperating with NGOs. And the aim is not to make the strategies just a piece of paper, but to do something actually. And instead of multiple objectives, which are not viable, to make less objectives, but that can be realized. That's all I can say. Thank you.
Thank you, Sofia. It was really concise. Our next speaker is Daniela Nikolić from Ministry of Health, Serbia.
Dobar dan svima.
Good afternoon, everyone. I've heard that my colleague quoted my saying when I said that I was hoping for arguments at this roundtable. I believe that these are the opportunities. Thank you for inviting us. These opportunities are very important, so we can hear all stakeholders and to see what are the impediments that prevent us from achieving our goals. So everyone should be aware of what is good and not good in their activities. All strategies have enormous benefits, but still a strategy happens in appropriate moments, in appropriate institutional frameworks, and for various needs. We used to have a strategy on drugs, but it expired, and it was written in a way that enabled realization of different activities, but other activities were not implemented. But it was just a pile of different works which were not synchronized, and due to financial insustainability of the things predicted by that strategy. I believe that these roundtables are thanks to our colleagues from NGOs from Bosnia and Herzegovina, from Montenegro, and from our institutional colleagues in Bosnia. This is the way that we gather maturity for certain type of a document. It is essential that that document is operative. In the example of Serbia, there is a law on plan system. It is so complicated that even the officials who are directly involved do not understand it. It also limits and restricts us because it was made for ideal countries and not for countries in transition, small countries in transition. So we have the laws of the 21st century, and you have real needs and demands which are very obsolete. On the other hand, that law has some advantages because it does not enable numerous strategies. We had strategy for glasses, and we had strategies for frames and for different parts of glasses. That's why we made that we need to make strategy. On the other hand, the documents, hierarchy of the documents has to be taken into consideration. And by using operative plan, we enforce institutional parts of the country to implement those activities by demanding the title of activity, funds that are going to be allocated, and everything. Therefore, strategy is that you have maturity of public opinion, political stakeholders, to have clear policy, in this case towards drugs. I have to support my Bosnian colleague who says that strategy on drugs without including other things is not complete. On the other hand, there is no, it is not too late for this, but what is to be adopted has to be operative. It has to be a decision and the will of majority of citizens. We all have to be ready for compromises. NGOs, they have advantages. State sector has to be aware of that advantage. That advantage is in their directness and not many stakeholders who are involved in NGOs. So we need to also, therefore it is very difficult to make national strategy if you don't have a clear direction in which one state would go, and if you don't have clearly defined competencies and the roles of institutions. And we have to admit that is not the case in our country. 1/3 of countries with are very similar to us. Sweden, as the most developed country, it has its policy regarding drugs, zero, but it is developed in line with a mechanism that provides different types of support and modalities that are at hand to a state to have an evidence-based balanced strategy. You should only start from one's own needs, organize roundtables which imply not criticism of different parties, but productive and constructive cooperation on how things are to be done and what are the first steps to do that. I believe that today's situation in Serbia depend not only in Serbia but in the whole region because bureaucracy is enormous in these countries, which is reasonable having in mind the tasks they are entitled to. The institutions have to show what kind of a document is to be adopted. The Secretariat for Public Policies is that governing body, and they have clearly stated what kind of document is to be realized in order to enforce all the participants of the public sector. My colleague Daniela often says it is not important how essential that is, but how many people are allocated. Drugs are important topic. They are important topic to all of us as parents, for example. And it's very important to know who is doing prevention, who is delivering such things. The users should be informed about all availabilities and of therapy and treatment. What is viable is usually reduced to personal enthusiasm of the employees, small number of staff who are doing their best, but the final result is not always satisfactory. We had an opportunity to work with European Center for Monitoring of Drugs, and the report that is the overview of the national position, and I'm mentioning that report because that was a sign of maturity and can help in the people in the region. By doing that report, you could come into the position to be faced with clear problem that you encounter and the obstacles that you have to overcome, what's the price of those obstacles, and the whole chain of different factors that you have to take into account at this moment, and how to do it most efficiently. It is very important to have consultant help from different stakeholders, UN, ODC, EMCDDA, regardless of non-monetary nature of that help. All our employees were very enthusiastic to collect data, and it is very important for us to have that register. We were allocated a consultant who inspired us. Therefore, I believe that it is of great importance that NGO has insight into the way when making decision, during the decision-making process. NGOs are just few organizations that are dealing with that. They alone cannot change anything regardless of their good results. But if a project or program, as Irena said for one, could be implemented on the national level, the sample would be greater. It is only needed to recognize what other people are doing as a good thing. It is important to speak about that. I do not advocate round tables who are meant to represent certain things that have happened. It is important to have a conclusion to be motivated and to know the direction in which we want to move. I have to say that cooperation with the civil sector until now did not have impact. The Ministry of Health, I have not been holding this office for a long time. The cooperation was sporadic, and where there is a need to give data someone, you are limited in the way that you can give those data. And from the myriad of data, drugs were always put on margins. At the Ministry of Health, we're lucky now, and I believe, as all my associates, that this new change in political sense and government reorganization, we got the minister who is interested, is very much interested in drugs. And I hope this will contribute to staffing of our department and better organization in which that cooperation will be done. We have made networks between institutions related to health data. We are, what is important to me is that maturity to make an act which would be projection on what the society strives to do, but in a way and where clear politics of one state is expressed, and to know the way how to enable financial sustainability of all the stakeholders. Thank you very much for...
Thank you, Daniela. Our next speaker is Smiljana Aleksić from Office for Combating Drugs of Republic Serbia.
Thank you. Hello everyone. It's my pleasure to speak in front of all of you on behalf of the Office for Combating Drugs. Also, I want to thank organizers and all the eminent speakers and guests from all over the world, Serbia and the region. Today I will briefly present to you the work of the Office for Combating Drugs of the Government of the Republic of Serbia and highlight official positions regarding office's plans for the future, especially when it comes...
sorry, Smiljana, slower.
Do you want it again?
Turn on and slower.
Can you hear me now? Okay. So, today I will briefly present you the work of the Office for Combating Drugs of the Government of the Republic of Serbia and highlight official positions regarding office's plans for the future, especially when it comes to the national drug strategy in the Western Balkan countries. Founded in 2014, the Office for Combating Drugs is the competent authority in Serbia for implementing drug policy in the Republic of Serbia and coordinating the work of public administration bodies in the field of combating drugs, as well as professional, administrative, and operational tasks in the field of combating drugs. Following the European integration process, the Office for Combating Drugs strives to harmonize the national standards and laws with EU regulations. When it comes to the national strategies in which Office had a role, I want to mention, as my colleague from the Ministry of Health, strategy for the prevention of drug abuse in the Republic of Serbia. And after strategy expired, the Office wrote down the report on the final evaluation of the strategy for the prevention of drug abuse. I will mention some of the main conclusions from that evaluation. And firstly, the Office for Combating Drugs reports directly to the government of the Republic of Serbia with more efficient administrative processes when it comes to the drug policies. Secondly, the office actively cooperates with civil society organizations and local self-government units in the Republic of Serbia. And also I want to thank Gorica for pointing that out earlier. Thirdly, external international partners, by virtue of the report of the Office for Combating Drugs, have comprehensive insight into the situation related to drug policies in Serbia. And for the end, the Office for Combating Drugs follows modern trends in the field of drug policies and tries to apply them on the national level through the drafting of public policy documents. Accordingly, the Office has established the cooperation with the relevant international organizations and institutions in the field of drug abuse, drug policies and preventions, such as MCDDA and UNODC. When it comes to the cooperation with CSO sector, the office has signed a memorandum of cooperation with 22 civil society organizations that are dealing with the prevention, rehabilitation, and resocialization of people in problem with drugs, as well as with the harm reduction programs. Many of them are today with us, and they are successfully dealing with many problems, as you can see. In the past 2 years, the Office for Combating Drugs has held several conferences, trainings, and workshops in a cooperation with CSO. I want also to mention the main goals when it comes to Office for Combating Drugs, and there are four. First of all, drafting laws, other regulations, and acts governing the field of drugs and the harmonization of regulations in this field with EU regulations. Secondly, coordinating the work of government bodies in the area of combating drugs, international cooperation with relevant institutions from world and also from region of Western Balkan, and for the end, cooperation with civil society organizations and local self-government in Serbia in order to raise awareness about the impact and harmfulness of drugs. At the end, within its competences, the Office for Combating Drugs will continue to provide all support to relevant and significant international actors, such as UNODC and MCDDA, but also national and regional partners and CSO. Also, Office will continue to support collaboration between law enforcement organizations and civil society organizations in every area, such as context of HIV and drugs, that especially UNODC is implementing through building programs on HIV prevention, treatment, and care. Thank you.
Thank you, Smiljana. We have just one short intervention.
Da, jedna kratka intervencija, posebno zbog toga što sve promjene najprije počinju sa jezikom, ako je to pozitivna promjena posebno.
If that's a positive change, it is very important that we know
termine poput drug abuser i drug abuse. Tako da nadam se samo u narednom periodu.
When talking about people using drugs, we do not use the term drug abusing and drug abuse.
Intervention. Thank you for intervention. To this moment, we have opportunity to hear about strategies in Southeast Europe, but from countries which are not part of European Union. In next 4 presentations, we'll have opportunity to hear about strategies in European Union, and our first speaker is Sanja Mikulić. Sanja is from Institute for Public Health from Croatia, ex-Office for Combating Drugs Croatia.
Ja se nadam da me čujete, evo hvala lijepo. Prvo bih se htjela zahvaliti organizatorima što su nas eto ponovo pozvali da budemo.
I would like to thank the organizers for inviting us to be a part of this conference. We have frequent and very good quality cooperation, so I'm always willing to respond to such requests. Before I give you the details as to what's new, we have already heard that cooperation in the area of combating drugs is very important. We have been doing so in the last 20 years in Croatia, and we are still not happy. There's always room for improvement, and you always find something new that needs to be further improved. When it comes to my presentation, So when it comes to my presentation, I would like to give you a couple of introductory remarks.
Uvodno samo nekoliko kratkih, nisam znala da će se tako sitno vidjeti, pa
didn't know that it would be so small. So I would like to tell you something about several trends taking place in Croatia. So we've had for several years a stable trend of persons who are subjected to addiction treatment. Addiction on cannabis and stimulative drugs is growing, but such users do not report for treatment. They do not come for treatment. So we still have to find a way as to how to include this population of consumers. We all know that our country is on the Balkan route, that it is used for different clandestine activities. We are fighting together to curb this, and our people from the Ministry of the Interior have participated in numerous actions. So they have confiscated, in the recent years, they have recorded a record number of confiscations. They do it either by themselves or in cooperation with regional or international organizations. So in Croatia, if you have on you drugs for personal use, that is not a criminal offense, that will be misdemeanor. So this turned out to be really very good, because this provided us with the possibility to dismiss the law enforcement agency that was only working this. So in Croatia, the quantity is not defined, the quantity of drugs for personal use is not defined, so it goes on case-to-case basis. So we have been talking also about money and funds. Certainly, for good implementation of policies, you need to have funds secured. So in the last dozen years, we've been developing this system, putting together all the ministries that are in charge of implementation of certain strategies, and then they need to have secured funds for implementation. So that process is a rather difficult one. We can figure out how much we spend on annual level to curb drugs. That's about 120 million euros, and most of that is spent on treatment. So that tells us that treatment is by far the largest source for spending, and the consumer of funds, by far the greatest consumer of funds. Since 2011, we've been working with assistance from grants that we receive every year. 2011, in 2015, in 2019, we did evaluations, and 2022 there will be the next one, actually the next research. These researches enable us with the possibility to to have a look at trends, to find out whether whatever we do through our strategies and policies works or not. So these are the results. If we continually implement prevention programs, if we invest money in different activities, and if statistics or prevalence shows totally different results, that means that something must be wrong. So that means that we have been working a lot in Croatia, but we haven't been doing things that we should have been doing when it comes to drug use, having in mind that from 2011 till 2022 the number of drug users has doubled among minors and among adults as well. So the drugs most frequently used, same as everywhere else in Europe, is cannabis. Other prevalences are somewhat lower. So when it comes to the national strategy, I am glad to present it here today as a formally adopted document. It was adopted in the Parliament, so it was passed on the 8th of February, and the document is published on our web page. Public Health Institute, Croatia Public Health Institute web page. The novelty in comparison to other strategic documents is that this strategy relates to all areas of addiction, alcohol, tobacco, and internet gaming and gambling, having in mind that this is an issue that's been rather sharpened, having in mind all the legal documents that were valid until recently. All these documents have been unified in one, and the Ministry of Health is the implementing body, of course in cooperation with the Public Health Institute, which is our institute. So we have evaluated probably everything that needed to be evaluated in the area of drugs. So we found out that it is necessary to implement activities which are which have a good cost-benefit ratio. So the last evaluation of the valid strategy was performed back in 2018. We would suggest everybody does evaluation of the strategic documents. And we could also say that external evaluation is much better than evaluation which is carried out internally by employees of the ministry. So we had two evaluations of the national strategy. One was done in cooperation with one Dutch institute as an independent expert, and through recommendations, the results of the evaluation, well, the results of the evaluation were incorporated in further strategic framework. It was recommended to pass a strategy that would encompass all kinds of addiction, and I would like to say that the cooperation between the healthcare sector and the NGOs providing psychosocial treatment, reducing damage and so on. So today in Croatia we have started with online interventions because we are quite aware of the fact that young users of stimulants are not really likely to visit us, to visit the existing networks, and that they need to be offered intervention from some other source. We were also talking about prevention and prevention programs. We implement quite a lot of preventive programs in Croatia which haven't proved to be effective. Now we try to reduce this, and one of the recommendations was also that we should try to simplify the whole system, coordination and decision-making system, and to provide education. When it comes to the methodology for drafting of the national strategy, I see that we all have similar experiences, because this is a document which sometimes is very difficult to pass. It is a long process. So we established our working group back in 2017. So we've been waiting for this document for quite a long time, but we are satisfied with that. And the process of drafting of the national strategy was managed by, until 2019, by the National Center for Drugs drug curbing in Croatia. So our office was attached to the Public Health Institute in 2019, so we are now a part of the Public Health Institute and Ministry of Healthcare. Before we started drafting this strategic document that we knew would redefine the system and everything, we tried to have meetings with all key stakeholders to find out whether we had consensus when it came to structural and systematic changes. So we had meetings with ministries that we knew were exponents of the largest number of measures: Ministry of Interior, Ministry of Health, Ministry of Science. And then, together with them, we opted for strategic and program changes, and this would not have been possible if they didn't agree to work on this with us. It's been mentioned in several presentations that all the measures, the objectives and goals need to be realistic, and that they need to correspond to available funds and assets. And also we have provisions in strategic planning which prevent us from mentioning any measure that cannot be connected to finance program activity. So unless something can be financed, it cannot be a part of the strategic framework. So ministries were slowly informed that they need to set aside funds for work of such bodies. So when we first established the Commission had 40 members, about 40 members from all bodies that were involved in implementation of some activities, so they were all parts of the working group. Beside them, the working group also comprised members of scientific and healthcare institutions. Following the first draft of the strategy, we offered it as for public counseling, electronic application which can be open for the public and closed for the public. So we invited in one part all the services, NGOs and so on to provide their contributions. So the draft was completed in the end of 2021 and it was sent to the Ministry of Healthcare for further procedure. The vision stated in the national strategy is that by 2030, which is the period of validity, the demand for illegal substances will be reduced. That means that social, health and other risks relating to addiction and addictive behaviors will be reduced, but that calls for cooperation of all state institutions, non-governmental organizations and others. When it comes to the structure of the national strategy, it was passed for the period of 9 years in line with provisions strategic planning valid in Croatia. We defined 3 policy priorities. Each priority comprises goals and objectives. The first priority is prevention, which is reduction of demand. So prevention, treatment, rehabilitation, damage or harm reduction programs and so on. And I wouldn't go into details, but measures and objectives are defined. So the second priority is reduced availability to drugs, same as alcohol and tobacco, in line with the legal provisions, and by this we primarily imply persons younger than 18 years of age. In order to implement all those activities, the main priority is to increase human and institutional capacities so as to implement nationally based and fundamental anti-addiction policy. So, also this calls for definition of measures, but also figures. So we needed to provide some initial figures or percentages and define some expectations as to what will happen in the next 9 years, whether these numbers will drop or increase, so that we can, now we need to find some indicators to figure out whether whatever we do works or not. So we will still have to think about that because, but we anyway only defined indicators that we can truly learn about. So there are also preventive programs that will be implemented in the school system that will have to be harmonized with the minimum standards Croatia adopted in 2017. However, not all school prevention programs are in line with them. One of the changes is that our existing county services will have to be strengthened as they will take over treatment of people addicted to gambling and persons addicted to alcohol. We also heard about naloxone today. We in Croatia also tend to provide for home doses of naloxone for self-treatment. We have currently some provisions in the healthcare department that prevent such distribution, but we shall try to find out how we can provide this service for persons who are addicted. As importantly, in Croatia, we monitor drugs, that is, people who are subjected to program for drug treatment. But we do not have programs for treatment of people who are addicted to gambling, smoking, alcohol, and so on. We need to incorporate this as well so that we can monitor prevalence of among persons subjected to this kind of treatment. The ministry has been cooperating with our institute. It is in charge of coordinating the strategy and monitoring the strategy. We have 27 indicators, and on annual level, the Ministry of the Ministry of Health reports to the government about implementation of the activities, and the government files the report to the parliament. The plan is still under construction. It will be for the period of 4 years, and it will define all measures and priorities as planned in the national strategy. The measures in the action plan will be described as to their purpose, who are the leading partners, who are other partners, and who is the source of financing. And now when it comes to vulnerable groups, the new strategy, same as the previous ones, were based on the principle of balance between demand and supply. So the champion of, well, in the area of human rights, persons addicted to drugs are a part of this. Certainly they are part of vulnerable population groups. It is necessary to include them in treatment early enough. When it comes to criminal offenses pronounced to such people, they should be subjected to alternative sentences or alternative sanctions. So the new strategic document provides for a range of interventions for vulnerable categories especially, and this can be done. This is either a part of the social system or a healthcare system or the penal system. Activities imply a whole range of services intended for vulnerable groups. One of such vulnerable groups are refugees and migrants. Croatia has had certain experiences with interventions aimed at this particular group. According to data what we have for February,
koji uživaju privremenu zaštitu u Hrvatskoj, od njih je sad negdje
18,400. January we have, by the end of 2022, we've had 36,000 migrants from Middle East, and this features also some of them certainly have problems with addiction. We participated in a Council of Europe program which was aimed at the composition of a manual for professionals working with migrants who are faced with drug problems. So this is intended for professionals who work with migrants. And here in our country, the Red Cross and Doctors Without Frontiers are in charge of implementation of this program, certainly in cooperation with shelters opened by the Ministry of the Interior. When it comes to the rights, if they have their status regulated, all the basic rights from primary health insurance are provided for them, same as social insurance, which relates to material assistance, shelter, and so on, except for children and pregnant women who are supposed to enjoy all those benefits. Certainly they would all have access to treatment, psychosocial and pharmacotherapy, same as the services, implementing programs for communicable disease and damage control programs. Rather than drugs, the problem with this population is their addiction on prescription drugs, because most of them who came to Croatia are rather addicted on prescription drugs than narcotics. This is not so characteristic of the groups from Middle East. Actually, they frequently suffer from psychological problems due to their traumatized state from their experiences, war-ridden and so on. Certainly, the problem can be in language barrier, fact that these people do not have any medical documents and so on. But when it comes to the topic of refugees and migrants, there are two most recent publications, one published by Pompidou Group about migrants who are faced with addiction problems, and EMCDDA, another one. So please bear with me for one more minute. The topic is communicable disease in people addicted to drugs. In 2022, we conducted a huge research on prevalence, and some other NGOs participated in this among persons who are a part of damage reduction programs. This was only intended for those who are not a part of the treatment system and who suffer from some communicable disease. When it comes to HIV, as Milutin said, we have very low prevalence prevalence of HIV, but we have high prevalence of hepatitis B. C, pardon. But everybody's got right to free aid. In Croatia, there are a lot of anonymous treatment and counseling centers financed within, from the state budget. We also have 6 or 7 damage reduction NGOs that are financed. So thankfully, this is really good that we are largely covered when it comes to harm control, harm reduction programs. I apologize if I was too long.
Thank you, Sanja. Our next speaker is Athanasios Theokaris. He is from the biggest association, Okana, from Greece, which have different programs. And please, Athanasios, floor is yours.
Thank you very much for calling us and inviting us here in Belgrade. But before I start my presentation, I would like to share some good news that we have. As you all may know, we have naloxone in Greece, nasal naloxone, till last November, the November of 21. But 2 days before coming here, we have great news. We have nasal naloxone in field workers, in professionals of our organizations, but the Ministry of Health gave us the approval, the final approval, in order to have the nasal naloxone to peers, to families, to all the persons that may need. So it's very significant to put a tick milutin to that box and to finally have this ticked. So just to say some things, as you know, in Greece we do not have an approved national strategy. We have formed this strategy, and it is not yet accepted, but it's in the approval process. And we gathered and we formed this strategy with budgeting, with targets, with aims, and with indicators for first time. And I have to say that we are the first organization that has performance budget indicators in our operations. So in order to understand how big is our organization, OKANA, as it's called, Organization Against Drugs, but I will tell you about that, that we have all the field of addictions now, and behavioral addiction, which is a new entry that we have. We have 4 main pillars covering prevention, harm reduction, and therapy, as well as reintegration. We have more than 9,000 beneficiaries, 20,000 in harm reduction, and 400 almost in reintegration. So when I went to the administration of this organization 3 years ago, we were almost 650 people, and now we are more than 1,000 people. So I would like to speak to you in another way, in a way of more operational, and show how this strategy may be in reality, which is much more, I would say, interesting and causing more motivation. So we tried to do all this expansion. We went to the addictions, and we went to low chains. So we have all the gambling, all the internet, all the alcohol, everything here. And we tried to implement and make reality all the NSRF programs that we had. We had almost 60 millions funded by the EU, and we are now at the implementation of this project in 95%. And we try to fill in the gaps that we had in several points of our activity. You will understand how. So we have almost 130 services all over Greece and more than 2,400 people for all the pillars that we have. The gap was there. The problem was probably mostly in the harm reduction area, where we had a gap in the hidden population, either more vulnerable populations such as HIV or LGBT population, and more, let's say, people like Roma and this kind of population. We had a high-risk population increasing in these populations, and we had many transmitting diseases, especially in Thessaloniki, that we have an epidemic, and we have to treat with overdoses. And of course, we had the problem with the immigrants coming to the country. So, in Athens, we tried to do more harm reductions, and in Thessaloniki as well. It was very essential that we had a very good contribution of the government, of the ministry, as well as the support of NGOs, of peers that were in the field. This is something that you cannot find everywhere. This is, for us, it was very crucial to have these people with us. Imagine that every day, there's no day that I pass the office of the minister, of the sub-minister, of the alternative minister, all the stakeholders, in order to change their opinion, their concept, and this people-centric approach that we have in the national strategy that we want. We opened NDCR, we opened shelter, day centers, we made many changes, and now these are, let's say, all these policymakers and politicians advertise this social policy because it's a kind of social policy, not only treatment. And the thing is that we try to convince them for this integrated system. The new services, the new entries that you can see, and the new services are much more than you can imagine. These are gathered here for the DCL for the inhaling kits. So you will see that we started giving inhaling kits till August 2021, because we saw that there is a trend on shisha, on crystal meth use that we have in Athens, and it's totally difficult for us. Imagine that we change our DCR, you will see, and we have injecting and inhaling room as well. We have the nasal naloxone, as I told you. We have two pilot programs, TTOS and Hippocrates. I will show you what they are, Escape and other programs. So imagine that this was a situation going outside, and we have distributed 8,000 inhaling kits, and last year in 2022 we had more than 600,000 cynics distributed. This is an enormous number. As you can see here, this is a totally different year. I wouldn't say years, but year, because this has exceeded the WHO average, and we are almost in 350 to 80 per person. I think that other 4 countries have reached this point. And this is only the beginning. And this has happened because lots of services have been implemented and have been developed, such as mobile units, such as social care and shelters, day centers, and things like that. We have this direct access and support unit for people who are coming directly to us, and they are treated at the first moment, which is very significant for us, because there you can have pathological, dental, and other testings that we can, and there we can find the first screening for HIV, HCV. So I can welcome you in the digitally our DCR in Athens. This is our new place with 12 seats, and if you can see, we have almost 20,000 visits, total visits for all the services for this almost 10 months, which is only for morning shift. We had an expansion of the shifts, and we will work 7 days per week. The government gave us the permission. And imagine that we have almost 1,200 per average per month, per day, per month, the supervised users that we have in the DCR. So we have all this. I forgot to tell you that we have almost 100 cases that we saved their lives with the use of monitoring and naloxone within this month. This is very crucial. And referring to naloxone, we had this in this situation in the field. So, new entries, shelters, day centers that we've opened, the biggest in Athens, 90 beds. We have other shelters as well. 2,026 people are benefited from July 2022, which is too many. It's 24 hours 7. We have other 3 in Athens, and we have other 3 in Thessaloniki and 1 in Patras. So 6 day centers and more than 1,500 beneficiaries. So the 2 programs that we should say a few words are TTOs and Hippocrates, Greek names, ancient Greek names. The one is for hepatitis, for HCV. It's the first program in Greece, I don't know whether it is in Europe as well, for beneficiaries of OST treatments. We screen them all and we connect them directly with the treatment in order not to lose in the way patients. So we took the patients with us and we brought them the doctors to them because we saw that the problem was there. And the other program, Hippocrates, is a program that we will have an automated system for HIV detection, since we have lots of HIV positives. Imagine that in our population, almost 70% of the people that we have are having HIV, and much more less are having HIV. Sorry. So it's of great importance that we cure this, and it's very easily treated now. So, Escape project for the first time with the help of EMCDDA. We have it in Greece. We have it in 2 cities, in Athens and in Thessaloniki, where we want to give some emphasis because Thessaloniki has an HIV prevalence great, I would say. We might have an epidemic there. I don't know whether it is a pandemic, but it's an epidemic trend. So we wanted to do and to see what's going on there. So another pilot program that we had, that we faced during our work, is a pilot program with the immigrants. It was the first program that it was implemented in Greece for detention centers, because we saw that people who were arrested and went to detention centers, they were left again to the field and they were coming back and forward. So we try to give them treatment, we try to give them psychosocial support and to screen them in order to keep them within the detention center and not to go around and transmit diseases or sell drugs or whatever this might have. It is of great importance that this program, our Minister of Health has included it to another funding, and we will have a new project on this all over Attica. This is of great importance, and this is, I think that our ministry evaluated all the situation, and we will take 30 millions from recovery fund, from NSRF, the next period, for the program that we have for public development, and we will have all this kind, all the naloxone project, all the street war action, and all the things that we want for the next period. So we have, as next steps, 3 mobile units that we will have in operation. We have 5 mobile DCRs that they will come probably in April in Athens. We will have 1 DCR in Thessaloniki, and many other programs that we will have. So the thing is that all this can happen. This is the thing. The only problem is that we have to insist. Thank you very much.
Thank you, Athanasios, for this presentation, for this excellent news about naloxone. Our next speaker is Paula Fristinou. She is from National Anti-Drug Agency from Romania. Paula, first is your... First presentations, please, because we are very limited with time. On the end, please. We are 2 to 3 here. That will be later.
Mi je uvijek drago koristiti vaš jezik. Moram priznati da mi fale stručni termini i zato ću nastaviti na engleski, da? Dobro, okay. Thank you very much for the invitation, for being here. I will be very short because we are running late and I do not want to keep you here. My presentation will focus on the national anti-drug, the national strategy on drugs, because we also changed the language in the strategy and we are in line with the European Union terminology, so we no longer have a strategy against something, but we have a strategy in the field of drugs, which is a positive change. Our strategy was adopted last year, so it's a fresh one. But before I go to the lesson learned in the process of design and implementation of the strategy and also evaluation, I would like to say just a few words about the institution that I represent. The national, and I will go to one of my last slides. It was supposed to be at the end, but I will start with this. The National Drug Agency of Romania is supposed to coordinate at the national level the response to the drug phenomenon, but in the 2 components, so drug supply and drug demand reduction. So we are an institution, a governmental institution, located in the Ministry of Home Affairs. I don't know if it's a model or should be followed or copied. It's something that has been working in Romanian for more than 20 years. So last year we celebrated our 20th anniversary. We are located in this same ministry, the Ministry of Home Affairs, but our activity is complex. Not only we formulate, we design the proposal, the first proposal of the strategy and other strategic documents, but the agency is also a service provider. We provide prevention activities in not only in Bucharest but also in the territory. You have there our administrative view and distribution of the counties in Romania. So we have representatives of this agency in all the counties of Romania and in all the districts of Bucharest. So altogether 47. of them. So there are these small centers that do at local level what we are supposed to do at central level. So it's a kind of replication from the central level to the territory, and it works. We provide not only prevention, but we also do treatment, outpatient treatment, methadone substitution treatment, and because we are always in contact with our NGO partners, and I'm happy that Nicoleta is here, we also have activities in the harm reduction field. And it is my personal view that having this component, this service providing component, it's very helpful for this other component, the policy, you know, the national policy component, because we are rooted in reality. I heard it a couple of times around the table. The strategies seem to be, you know, difficult to implement because they speak in a different language and specialists do not understand it. Or it's very hard for them to implement something that is set from above, you know, it comes from a plane. Well, our strategic planning system, it's rooted in reality because of what we do in the territory, because of our direct contact with drug users, because of our direct contact with the general population, school population, so we are present in all this area, and because of our connection with the non-governmental organizations that do an excellent job in Romania. Let me just forward to something that I wanted to point out, very strictly related to the national drug strategy. As I told you, the National Drug Agency has a mandate from the government to design the strategy, and there is a very complex process. This document has to go through until government approval is given. And in all these processes, in all these stages, the National Anti-Drug Agency is present and is actively present. There were a lot of working groups, there were a lot of documents that were being forwarded. We received amendments, we analyzed all the amendments, some of them were accepted, some of them were rejected, so it was a lengthy process. What I wanted to point out is that, let me just go back to my presentation. In this process, we asked for approval from all the ministries involved. Being such, you know, a complex strategy, all the ministries in Romania have responsibilities in implementing this strategy, so of course they were consulted. Of course, some of the deadlines we set for this strategy, I told you, it's a new one. We adopted it last year in March. Some of the deadlines were influenced by government instability, so we also have that. But having in mind the previous stories from Bosnia and Herzegovina, I will just go back to my colleagues and say, it's nothing. What we had is nothing. Yeah, relax. Okay, and one of the ministries that already signed the document was reorganized and a new one appeared, so the process had to be taken all over again. So this is why it lasted a little bit longer than expected. And this is why the timeline of the strategy was changed from 2021 to 2025 to 2022 to 2026. So again, a four-year strategy with an action plan that is very detailed. It has deadlines, it has indicators, it has responsible parties, benchmarks, so everything that should be in a strategy. So this is just a graphic representation of the process. A document, our document, the strategy had to go through until it was adopted by the government. In short, our strategy is in line with the UN strategic framework, of course, with the European Union drug strategy. It has objectives, activities, and so on and so forth. We try to make it tangible, but we consider it a document that is flexible enough to ensure activities are implemented in the field, you know, in line with emerging tendencies of the drug phenomenon. Okay, so these are a couple of the ministries and authorities that are involved in the field, so just a couple of them because they wouldn't fit on the slide. Okay, but besides this strategic document, I would like to point out that this strategic document that was put forward by the agency is part of, let's say, a bigger picture that makes up the policy, the system of public policy in Romania. We have a government program, we have other strategic documents that include some responsibilities for some ministries. Some of them are very focused, some of them, you know, point out our agency, you should do that. So all together, all these strategic documents, they make up the public policy strategic planning system. What I want to point out, and it was mentioned a couple of times around the table, the need for a strategy to be funded. So the need for resources. This is how we try to fund the implementation of the strategy. So we have two national programs. Their names are somewhat similar, but they refer to two very different things. The first one, it's a national program that was designed to support the activities of the National Anti-Drug Agency, and the second one is a funding program for NGOs in Romania. So NGOs are supposed to apply to write projects. Projects are selected according to very strict criteria, and they should receive funding for their activities. Altogether, those two programs amount to around 10 million euro, and their implementation should be developed over 4 years until the end of the current strategy. As I told you before, at local level, we have local action plans. So deriving from the national strategy, from the national action plan, we have these local action plans on drugs. Again, the centers of the National Anti-Drug Agency were the ones that made the first proposals, the first designs of plans, and that brought together local public authorities at the same table. And there was a lot of, working groups, data analysis, local diagnose, a lot of meetings and debates before these local plans were approved, and they represent really very tangible activities that should be done at local level. Okay. Next. For Bucharest, again, it's a local action plan. For Bucharest is only one. In the past, we had 6, because I told you that Bucharest is divided into 6 districts. So we chose to do things differently, and since last year, there is only one plan for Bucharest. Again, very tangible, very concrete activities, and with strict deadlines for monitoring and evaluation in the plan. Some of the activities have already been made, trainings, prevention activities, and other activities. Okay. As I mentioned before, the cooperation with the civil society structures and also with the academia, with universities, is very important. For developing the public policy in the field. There are consultations and joint activities we do all the time. And of course, regular monitoring, evaluations at the end of the strategy. These are this is the normal process of a strategic document. I will not take any more of your time. Thank you very much.
Thank you, Paula. Our last speaker, but not least, is Jože Hren, our dear friend from Institute for Public Health Slovenia. Slovenia is today victim of alphabet, last in schedule. Jože, please.
Thank you. Thank you, Nebojša, for giving me the floor. And I hope I can do take some more time because it's already 3 o'clock and you have announced that we should finish until 3. But I will be short. I promise I will stick to maybe key words from each of my slides so that you can then maybe more easily follow and take home what is really important in my opinion. But before I start with my presentation, I wish to really express my gratitude to Mr. Pekic for enabling this event and to Mr. Milosevic for doing all the organization. I'm aware how hard it is every time to organize any kind of event and to bring all the people here. I think really good experts. I learned a lot today. So many things are going on in this region, and I'm really happy to be here. As I said, I will focus on key words. In this slide, I wish to share some figures about Slovenia. Although the country is relatively small, with only 2 million. What we are noticing, and I'm aware that we are not the only country that is confronted with this problem, it's aging. You can see that by the year 2060, almost 1/3 of the population will be equal or older than 65 years. So I think this is a reality, and we are already now trying to confront this issue. But if I move to
that direction, like this, I can change for it. Doesn't work. No. Okay.
There must be 2 of us. So, and it's always a pleasure to work with Liliana. So only a few facts about epidemiology in Slovenia. On your right-hand side, you see different programs that are available for different populations, but on your left-hand side, marked or written in a dark black letters, you can see our priorities for the next period of time, which means until 2030. We'll focus on early prevention. When I mention early prevention, I wish also to say that maybe you are not all aware of that, but last year Slovenia, together with France, proposed at the CND a resolution on early prevention, which was heavily negotiated and at the end adopted by the CND, and here we had really a major support by the UNODC Office for Drug Prevention. So that's one of the priorities of Slovenian drug strategy, early prevention. The next one is it's hepatitis C elimination by 2030. As it was mentioned by our Greek colleague, this is very important aim, also listed in relevant WHO documents, and our efforts will be focused very much on several activities with the aim to eliminate or eradicate, as our Greek colleagues use the word, so to eliminate hepatitis C by 2030. And the last word I wish especially to underline is recovery. By 2030, we wish to work really hard on this relatively new concept in Slovenia, meaning that we will employ especially occupational therapists in the network of centers for prevention and treatment. We have 21 centers for treatment and prevention throughout the country, and we wish to employ experts who will provide occupational therapy to drug users. About drug legislation, it's important to say that already in 1999, Slovenia decriminalized possession of any illicit substance for personal use. This year we have started to amend this law for different reasons, but this will not be changed. And it's important to say or to mention decree on classification of illicit drugs. This document, when it, let's say 15 years ago, included only 196 substances, whereas now we have 536 psychoactive substances listed in this document. So a lot of work every year is invested in this document. Well, about our national drug strategy, currently we don't have one. It's in the process of drafting. We hope that in the next 1 or 2 months the document will be discussed and then approved in the parliament. But an anecdote I can say about it, the previous drug strategy was consisted of 40 pages. And when we started drafting our new drug strategy with my colleagues, we said, well, let's try to write it shorter, a bit shorter. And last week, when I was communicating with our governmental office for legislation, we discovered that there are 66 pages now. So we weren't very effective concerning that. In this slide, what's important to be mentioned is that Slovenia spends for drug demand reduction services annually around 14 million euros. So 14 million euros for drug demand reduction services are spent every year almost. But the fund is increasing, the sum is increasing, but around 14 million euros each year. In this slide, which took me a lot of time, but I will say it in 2 words, the main coordinative body is Ministry of Health. So we are the ministry responsible for drug policy in the country, and we serve also as a secretariat for Governmental Drug Commission. And those 2 entities then work with all the institutions that are mentioned in this slide. And about refugees and migrants, immediately after the war started in Ukraine, almost a year ago, the government adopted a document, guidelines for emergency health services for migrants and refugees. So it's a basis for all of our activities with migrants in the country. And it's important to say that when migrants from Ukraine, mostly women with their children, came to Slovenia, there are around 7,000 of them now, we started again to cooperate with UNODC Office for Drug Prevention to adopt the program called Strengthening Families Program. So at the beginning we wanted to adopt this program for Ukrainian refugees. But then with the time, and because of the fact that Ukrainian refugees were dispersed throughout the country, and they very easily and simply integrated into the society, so they were in fact they have this option to use all the services that are available to all the other citizens, so they can use them as well. So all treatment, social health services, prevention services that are available for every citizen, those services are available also for Ukrainians. So there was then no need to adopt this program for Ukrainians again. And but saying that, and it's important to be aware of the challenge that that we are trying now to assure really high-level quality services and best practice for all, including for refugees from Ukraine. And saying that, I wish to say only two more things: that all the legislation and epidemiology are available on those two web pages. And my last slide is, we started with one word that is very common in this region, which is dobar dan, but also we can say hvala, thank you, which is
Thank you, Jože. We can spend last few minutes for comments, for some discussion very shortly. Denis, you want to say something?
I don't remember. I want to suggest maybe DPNC staff, DPN staff to organize all NGOs and institutions who provide free of charge services for migrants. And regarding Okana presentation, I'm thinking about this, and to put on some type of virtual map or map for mobile phone, and to put in migrants networks with this information. It's useful for them and useful for us for social cohesion and the control of this population.
Yeah, Marius?
Yes, of course. So, first of all, after all this day, let me introduce myself. I'm a board member here. I'm Marius Adzemis from the Greek Association of People Living with HIV Positive Voice, a pioneering peer-led harm reduction collective initiative of HIV positive people. I want to thank the DPNC office about organizing this event here, especially my friend Milutin Milosevic and Nenad. And also I want to thank everyone who is here, but especially Mr. Theocharis from Okana and Mr. Fotiu from our focal point, who accepted our invitations. And also, last but not least, the UNODC team. I have to admit, I'm very impressed for your openness and your condensation. And I really enjoyed that we had, let's say, an informal meeting yesterday in a surreal taverna of socialist era, among the statue of Lenin and pictures of Joseph Stalin. We had an interesting conversation, though. I would like just to say something. It's food for thought. It's nothing more than that. Count today how many times you heard the word HIV. Count how many times you heard the word drugs and drug users. And count how many people are here, HIV positive, former or current drug users, starting from me. And then you will have an answer about the direct negative impact of the absence of the directly affected community from the strategies that are directly affect our lives. Thank you so much.
Thank you, Marius, for this inspirative speech. On the end, I just want to thank you, everybody, for participation, and to thank our translators and our technical support. Just to add something.
No intervention or presentation, but just to really thank also in the name, of course, of the EMCDA again to have been associated to this event. It has been, I think, very, very useful for us to see some known faces, to discover new faces, and also for those that don't know yet that we have initiated a new project, cooperation project with the Western Balkans for the next 4 years. So we will be very often, I hope, in the region meeting with all of you, not only at regional level, but also at national and local level. So we really look forward to continue the cooperation with all of you. And thank you again to Milutin, but also to Milan and to all the people around the table for having associated us to this event. Thank you very much.
Thank you, Frederick.
Can I just say?
Just closing remarks from Fariba, and we'll finish.
No, I just wanted to also raise my voice of thanks to Mr. Pekic. All of you, really, it has been such a rich discussion, such a learning experience for us to, for the first time to really have this discussion on harm reduction in the region. So thank you for organizing, thank you for having us here, and thank you for this discussion. That's it.
Thank you again, and we finished.